to different counties, and if you want to email me and ask for the link, if you want it specifically, I can have Carrie get my email address out in the chat. Carrie, what do we got for people? We had 60 plus just a few minutes ago.
Yeah, we're approaching 80.
Okay. So great that we can do this with so many people. The benefits of Zoom, and perhaps all of us learning about Zoom during COVID. We have Dr. Anigas starting this morning. She's going to focus on the negative impact of a child's neurobiology as a result of drug-endangered children. She is the medical director at Marshfield, correct?
Marshfield Child Advocacy Center, yeah.
Marshfield Child Advocacy Center. And I will let you take it away, Dr. Anigas.
Thank you. Yeah, not Marshfield Clinic. I'm not the medical director for that. I'm the Child Advocacy Center. So.
Gotcha.
Okay, very good. Just a couple of things before I get started. If anybody happens to have questions, I'm assuming there's a chat box you can type into. Is that right, Beth? Or do you know?
Yes.
Okay. And what we might have to do is wait until the end for questions. There is, I think I've got some time set aside for that. Versus unmuting and talking, if that's okay, just because it might kind of disturb the flow of things at this point in time, unless it's really urgent. Okay. So something else, I'm going to probably turn my camera off, because if you've already noticed, it gets really glitchy. Just like right there, you'll start to see me kind of flash. And yeah, that's very distracting. It's no good for you guys. So I'm going to go ahead and do that now, and then I'm going to get started. Okay. All right, so the title of my presentation is The Tip of the Iceberg and the Effects of Drug Endangerment on the Developing Brain. And as Beth mentioned, this is really a talk about neurobiology, and what that means is the structure and function of a child's brain and how their environment, especially that drug-endangered environment, affects them. All right, so I have no professional disclosures to make, or no financial disclosures to make. I don't get paid for, talking about specific aspects of this talk. I'll also tell you that I am very passionate about this work. And I spend a lot of time with drug endangered children, so this really means a lot to me. And I'll just put it out there ahead of time. Some of my statements, I don't want anyone to feel that I'm making any judgments. I just feel very strongly that we have to be doing more for these kids, and I will say that essentially. So the objectives today, first is to understand, excuse me, how that drug endangered environment affects the developing brain. We'll explore how using this information can support and enhance investigations, but also how it relates to, or how we can relate this to influencing a treatment pathway, both for the child, but also for the offending caregiver. So I always like to say, I truly believe this, that the work we do is so hard. We see these kids, we see the environments they're in. It's heartbreaking at times. And it's incredibly important work that we do. Prior to COVID, drug use and abuse in this country was already at an all-time high. It was estimated that the number of children exposed in these environments was upwards of almost 9 million children every year. That's 13% of the entire pediatric population in this country. However, in 2020, we have seen a whole lot of increase in the number of search warrants, the criminal charges for possession, and subsequent increases in CHIPS petitions for children that are drug endangered. At my center, at the Marshfield Child Advocacy Center, we typically would average about 40 to 45 cases every year between 2017 and 2019. In 2020, we actually saw 88 DEC cases, and that was after we opened back up middle to end of April, because we were shut down for about a month and a half. And that's an overall 110% increase just in drug endangerment that we saw. I'm sure that your jurisdictions are seeing similar increases, and although I wholeheartedly agree with the stimulus checks going out, unfortunately, for many of the caregivers that we work with, their inability to make the right choice with that money, I think we're going to see more issues in the next month to 6 weeks. So I'm so thankful that these kids are on our radars. Just a few years ago, child victims were really of little consideration during the execution of a search warrant. Now we're utilizing human services at the scene, and in some cases victim advocates as well, in order to really make this disruption as trauma sensitive as possible. Unfortunately, I do see regularly MDT members in general kind of reach for that, what I like to call the low-hanging fruit. Drug possession, manufacture, and sale are, of course, paramount in these investigations, but they become the absolute focus of the investigation. Now, I get it. I get why it's important. I mean, these are tangible things that you can take to a judge or a jury or whomever, and therefore they're easier to prosecute and easier to win. And DA's offices love those tangible aspects because it's much easier to move these types of cases forward. But if we only look for that low-hanging fruit and we only pursue the charges and petitions related to a child's direct exposure to toxic substance, we are discounting the totality of their victimization because of that drug-endangered environment. By not recognizing the effects on the child's overall health and well-being, we will not improve and we cannot maximize the outcome for the child. And by not looking at neglect, we essentially remove the accountability from the caregivers as to the effect of their actions on their child. In many cases, children are removed, in probably the majority of cases, maybe placed with grandma, maybe put into foster care, but then that's it. And we tend to wipe our hands of this and walk away. Is it enough to recognize the children who are exposed? Is it enough to remove them from this environment? In my work at the CAC, we have evaluated about 200 children over the last 4 years for drug endangerment. And the dysfunction and disability that we see in these kids is absolutely mind-blowing. Unfortunately, if high-quality interventions aren't implemented and continued, these children will likely experience a lifetime of disease and dysfunction, a lifetime of problems. Right now, from an investigations perspective, what I see from my partners is that we are really just recognizing the tip of the iceberg, okay? And my goal for you today is I really want you to walk away from this presentation with new eyes, fresh eyes. Whether you're CPS, law enforcement, DA's office, Corp Counsel, advocacy, or another member of the multidisciplinary team, I hope that you are able to recognize the amount of adversity that these children, the children living in these drug-endangered homes, experience, and how those experiences shape their brains and ultimately shape their futures. So for today's talk, we're going to focus on two main domains regarding exposures in the home. First, those unsafe conditions and things like exposure to the substance, of course, that is a danger to the child. Other drug-related exposures and events, supervision, or truly in this case, a lack of supervision, and co-occurring abuses and what that does to a developing brain. Then we'll switch gears and talk about the neglectful environment. These environments tend to be very chaotic and unkempt. There's usually not very good nutrition being offered. There's not good general care for the child. The caregiver tends to be relatively unresponsive, and there are definitely not a lack of positive experiences in this environment. So we'll first focus on the unsafe condition. And the most obvious safety issue in the drug-endangered home is that potential for direct exposure to the toxin. Now, research in children is limited. Obviously, we cannot expose children to drugs. We can't give them methamphetamine and then study the effects in the lab. That would be obviously unethical. And in the real world, there's generally too many confounding variables to be able to really tease out how drugs specifically affect a child's brain. Really, because there are all sorts of other neglects and other exposures going on to be able to determine what exactly caused a specific problem. We do know, though, that chronic adult users of drugs like meth, coke, and heroin will experience problems, dysfunction in very specific areas of their brain. So that information could theoretically be translated to children as well. So methamphetamine, which is one that I really like to talk about, I think the science behind meth is really fascinating. But meth has a huge affinity for very specific areas in the brain, one being something known as the hippocampus, which is our memory center. So if you think about some of your long-term meth users, they probably have difficulty with memory and with learning. The cingulate gyrus is another area of the brain that meth has an affinity for. And for these individuals, they tend to have motor issues and problems with tremors, problems with controlling their motor movements in general. And then the last area, well, one of the most studied areas of the brain affected by methamphetamine is the prefrontal cortex, which is what we call our executive functioning center. And that's really where our high level decision-making and thought processes come from. These are your big girl and big boy decision-making, right? But other drugs also have an effect, and heroin, for instance, and other opiates can cause alterations also in areas of the prefrontal cortex that cause dysfunction with intellect, abilities to plan, abilities to perform multi-step tasks, and in memory. And then drugs like cocaine affect our ability to have neurotransmission. They affect our neurotransmitters and the receptors for those. Neurotransmitters are the chemicals in the brain that allow the neurons to talk to each other. And when an individual has long-term cocaine exposure, we'll see issues with that that can lead to psychoses and other mental problems, or mental health problems. So it's really common sense, I think, to think that if these drugs are neurotoxic in an adult, they're likely neurotoxic in the fetus or the child as well. The magnitude, though, would be dependent on the child's stage of development. So I'm sure we all recognize that we start off as 2 cells, at the time of conception, and hopefully we grow into the fully functioning adults that we all are. But there's a lot that happens in between that two cell step and what you see as the finished product. So the neural structures in the brain grow incredibly rapidly from conception until about 5 years of age. There's a lot that's happening, obviously, prenatally. And once the child is born, we hope that they have about 100 billion neurons or nerve cells. So that prenatal period and even early infancy are so important for laying a very good foundation for overall brain development. In the later periods of the fetal growth period, the neurons, the nerve cells start to move outward. They start to form connections amongst themselves. And this is where we see the bulk of the brain being gained. So you look at this, photograph of CT scans of brains a child's brain at different points in time, you'll see that just the rapid amount of growth from 1 week of age, 3 months of age, 1 year, 2 years, but then between 2 years and 10 years, there isn't a significant amount of growth, but there is growth. At 3 years, we expect to see the infant's brain about 80% of the adult volume. So a lot has happened from conception until 3 years of age. By 5 years of age, we hope to see the child's brain being at 90% of adult volume. And then from 5 years until 25 years or 30 years, we continue to see small amounts of growth, but a lot of neural connections are being made in that time. So really until an individual is 25 to 30, that brain is still developing. So it's important, though, to recognize that during this very rapid period of brain growth, especially in that prenatal period, there is so much that can go wrong if there are insults. The overall effects of toxin exposure are going to be directly related to that timing of exposure. The earlier the exposure in the prenatal period, the more harm that can be done. But that holds true even after the child is born. When there is prenatal exposure, the likelihood of these direct neurobiologic damage is much greater because, for a couple of reasons, the fetus and mother, first of all, share a circulation. So whatever she takes into her body, the infant's going to be fully exposed to, or the fetus will be fully exposed to. But also, again, because of that very sensitive timing, because that brain is growing so rapidly. So when mom ingests a drug, the fetus is going to have the same biologic experience. Whatever organs the drug affects in mom, whether it be her kidneys or her intestines and her brain, if she's getting high, the fetus will have the exposure in the same areas of their body, okay? So prenatal exposures can have multiple effects, and I've already alluded to all of them, I believe. But first is that there can be an overall reduction in brain cells. If a fetus is exposed early on, they may not have that 100 billion cells for maximum brain capacity and brain growth. There might be a reduction in their neurotransmitters and neurotransmitter receptors. Those are those chemicals, again, that allow the cells to talk to each other. And there also might be a reduction in the neural pathways overall. And all of these things together will reduce the overall size of the brain and limit its function, limit its ability to work well. So acute intoxication in that postnatal period is one of the few concrete examples of how dangerous these exposures can be. And it's a concrete example because we can actually see the symptoms that the child portrays when they get into mom's or dad's stash. So a toddler who gets a hold of a rock of methamphetamine will, at a minimum, develop externalizing symptoms like irritability. They're going to be really crabby. But they also, we see in the cases that we've had hospitalized, they develop stereotypic behaviors. So they have those really odd motor movements. And they might develop high blood pressure or hypertension, which is generally short-lived. But they can also develop very life-threatening conditions from these acute intoxications. For instance, some children may have seizures from getting into methamphetamine. We've seen on a couple of occasions children developing something known as rhabdomyolysis, which is a breakdown of the skeletal muscle. And then that can throw a child into renal failure. And then, unfortunately, we also can see cardiac arrhythmias, which can lead to death. Those can be, actually, both rhabdo and the arrhythmias can be deadly. Whereas exposure to other drugs like opiates or synthetics, we know very well that they lead to CNS depression and respiratory failure in adults, but this can also happen in the child who gets a hold of, I've had situations where they got into grandma's methadone and needed to have emergency treatment from that. It is a lot more difficult, though, for us to pinpoint the exact effects of postnatal exposure, not the acute exposure, but just that long-term exposure. Because the brain continues to grow and develop during that postnatal period until about 5 years of age, these toxic exposures will likely cause similar structural damages that we see in adults. But because the dosing related to their more passive exposure is smaller, the amount of structural change is probably also less extensive, but not necessarily absent. We can still see changes on CTs and MRIs, for instance. But this is, again, difficult to study, and so it's difficult for us to make any definitive statements that whatever changes we see are from direct drug exposure versus drug exposure and everything else that goes on in those homes. So whether the insult occurs in utero or postnatally, the effect of exposure to these toxins is potentially devastating on that developing brain. I want to liken it to, or I like to liken it to building a house with half of the lumber necessary, or building a house with wood that's infested with termites. The outcome is a structure that does not have, it doesn't have integrity. It's not strong. In other words, for our brains, when we have these factors, the brain doesn't grow and develop appropriately. So when we think about unsafe conditions of the drug-endangered home, again, aside from the direct exposure to toxin, there are several other potential exposures and events related to the caregiver's drug use that will threaten a child's overall health and well-being. Drug paraphernalia is an obvious risk. Many of the homes that our MDT members go into, they find needles and razor blades, lighters, things that can be easily accessed by the children. There are also likely going to be residues on some of these tools that are used, residues on the scales and, you know, and on any implements used to heat and melt some of the toxins. Often we hear about weapons being in the home that are usually in reach of the child. They're usually loaded. There's usually not a safety lock on. And this, again, poses an obvious risk to the child's well-being and safety. But maybe less obvious are risks from other unsafe scenarios resulting from the caregiver's use, manufacture, or sale. So the meth lab was one that we talked about ad nauseum a few years ago. This has really seemed to fall off the radar because a lot of our drug is not necessarily produced locally and it's brought in. But although recently we did just have a big drug bust in a motel in Stevens Point. So it's not gone, should not be forgotten by any means. Trafficking also exposes children to life-threatening potentially scenarios, as you know, drug sales can go south really pretty rapidly. And if the kids are there, and many times they are, they're going to be in the mix. Then there's exposure to other users who might be hanging out with mom and dad. Maybe it's a drug house. And these individuals, again, because of their substance use, likely have poor decision-making skills themselves, and they could physically or emotionally harm the child. Supervision is an important piece when we think about safety in these homes, and really more to the point, inappropriate or lack of supervision. It's something that we see routinely in these environments, and sometimes this is the reason that the caregiver becomes known to the authorities. They're foiled by their toddler. Chances are, you know, when a caregiver is under the influence or coming down off of whatever substance, they're less likely to be providing adequate supervision. And we've had several cases here in Marshfield where a toddler was found wandering the streets of Marshfield wearing only a diaper, sometimes in frigid temperatures, sometimes in the middle of the night, while mom was found or dad was found to be sleeping off whatever drug, you know, at the home. We also recently saw two sisters, both under the age of 10, who, while mom was again recovering from her use, started a kitchen fire. So these were, again, very unsafe scenarios. Co-occurring abuse is something that we also have to think about. The risk that a drug-endangered child will suffer from some other form of abuse is very, very high. Excuse me. What we know from several studies is that traumatic experiences are rarely isolated. They are not a one-off. It's not like physical abuse happens and that's it. It happens one time and we're done. There's usually, if there's one abuse, there's usually multiple. And drug endangerment is no exception to this rule. Now, I assume that many of you, hopefully most of you, are familiar with the ACEs studies. I'll give you a quick synopsis. So essentially, ACEs are adverse childhood experiences. Back in the 90s, there was a researcher and a physician who published, starting off with one paper, but it became about, I forget, over 70 papers now in the end, that looked at adults' recollection of ACEs while they were growing up. And they were surveyed. There were 14,000 survey respondents, and they were asked about what types of abuses or household dysfunctions they experienced as a child. That information was then linked with the individual's current or recent health problems, including physical health and mental health. So we actually reproduced the study back in 2016 using residents of central and northern Wisconsin. And what we found was that when asked about specific types of abuses in their home, central Wisconsin residents disclosed, or 20% of them disclosed having a history of physical abuse. 17% reported having a history of sexual abuse while they were children, and 40% reported being emotionally abused. Now, just so you know, these numbers are very close to what the larger ACEs study found back in the 90s. And there's also been other studies around the country in different states that have looked at this, and the numbers tend to be very similar across the board. One area that I'll say that we were different, and unfortunately we were worse, was in the emotional abuse realm. Again, our respondents reported about 40% of the time that they had emotional abuse in their home, whereas the larger studies out of California and other states only showed about 30% emotional abuse. So, but when we looked specifically at those respondents who also reported drugs in the home, and then we looked at physical abuse, sexual abuse, and emotional abuse in that subset, we found something really interesting and actually a little frightening. The rates of physical abuse went up from 19% to 33%. So if you were living in a drug-endangered home, the rate of physical abuse increased by 74% over the general population. Rates of sexual abuse almost doubled if there were drugs in the home. And rates of emotional abuse increased by 56%, which again is significant. What this showed us was that individuals living in a drug-endangered home were much more likely to suffer physical abuse, sexual abuse, and emotional abuse, again, compared to that general population. So we also screen our drug-endangered children for their own historical ACEs. And so we have caregivers complete a survey, or the same ACEs survey that was used in these studies for children under 10. For children who were 10 or over, they actually completed the survey themselves. And what we see being reported is consistent from year to year and is very telling. So here's the graph of our respondents, and what you'll notice that the range of ACEs in our group was anywhere from 0 to 10. We actually had one child report having 10 ACEs, and 4 was the median reported. That means it was the number that was reported the most times. But all of this area under the curve represents all of our children. So again, a significant number of ACEs being reported. And this curve that I'm showing you here is for all of our data. But when we broke it down by age group, for infants and young children, school-age children, and then children that were 10 and over, the curve is really the same. And the median reported ACEs was 4 for those kids as well. Now you'll note, whoop, sorry, I went the wrong direction. You'll note that 10% of our respondents had 0 ACEs. And that's really interesting because almost every child that we saw had been pulled from a home where drugs were found. So they were living in a drug-endangered home. So this just goes to show that the caregivers who are completing the screens or the adolescents who are completing their own screen might be in denial about what is actually happening in their home. 91% of the children that we saw reported at least 1 ACE. And of that 90%, 88% had 2 or more ACEs. So as we said earlier, abuse and adversity are rarely isolated events. These individuals are reporting that multiple bad things are happening in their home. In our population, the average, not just the median, but the average number of ACEs across the board was 4. And 59% of our children, almost 60%, reported having 4 or more. And this is really important because in all of those ACEs studies, including the one that we had performed, individuals who experienced 4 or more ACEs were significantly more likely to adopt risk-taking behaviors, such as drug use, alcohol use, promiscuity, but also have overall poor mental and physical health outcomes as an adult that were not related to their risk-taking behaviors. So what this data tells us is that the children in our population had at least one adversity, more likely than not, and their risk of experiencing another form was incredibly high, and that 60% of the patients that I saw are going to be at significant risk for health impairments related to their adversity. So what is the significance of being in a home where things are unsafe? Why does this really matter? Aside from the threat of physical harm to the child, these scenarios, whether it's drug exposure to drugs themselves, or if it's the unsafe conditions, the lack of supervision, the co-occurring abuses, these are very stressful for a child, and they're very stressful for an infant as well. People tend to poo-poo the role that this has on an infant. Well, they won't remember. Well, they may not have an episodic memory. They may not have a distinct memory of something happening, but their brain does remember when they were under stress. So whenever a child or an infant is scared, whether it's from being physically hurt or being yelled at or being alone or alone in an environment with strangers, their brain perceives this as a threat. And this elicits a stress response, a very specific response in their brain. This is an important survival tactic or characteristic, excuse me. This is our fight or flight response, as I'm sure we're all aware. Think about, in prehistoric times, this was a necessary thing. This response is what enabled us to escape from wild animals. It kept us alive. So again, this response is normal and it is necessary. But when the threat recurs or the threat is chronic, the brain rewires itself. It adapts to this threatening environment. It adapts to help the child survive, because that's what the brain is supposed to do. And the result is an overactive, exaggerated stress response that can be triggered by the simplest of stimulus. You can look at a child wrong. You can tell them no, and they fly off the handle. Unfortunately, this is not easily reversed. The adaptation that occurred in that threatening environment does not go back to normal when the child is removed. This adaptation, which helps the child survive in that abusive environment, becomes, quote, maladaptive in a normal environment. So I want to switch gears now and talk a little bit about neglects that we see in the drug endangered home, and again, the impacts that they have on the child's brain. So take a look at this house. I'm sure all of you have stepped foot in something like this. I fortunately have not, but I've seen lots and lots of photographs of it. This may not represent every drug endangered home, but there are many that look like this. And aside from the obvious mental and physical health hazards of living in a home like this, I want us to think about this from a different perspective. I'd like us to use this picture as a metaphor for the life of the drug endangered child. How would you describe this home? At first glance, I would say gross, but it looks very chaotic. Where am I going to sit? Where am I going to sleep? Where am I going to eat? What am I going to eat? Are there bugs? The questions would be endless. The stressors would be endless. Do you think that the caregiver in this home leads a structured environment for their child? Do you think that they provide adequate nutrition for their child? Do you think they provide appropriate cares? Are they providing nurture? Are they reading books? Are they playing? Are they talking to their children? Probably not in a way that's appropriate and positive. So when we look at our children at the Marshfield Child Advocacy Center, we actually look at a lot of these pieces, and the data that we have from our kids that are in drug endangered homes tells us that the questions I just asked you before, these things are not happening. From a nutritional standpoint, 70% of our patients had laboratory evidence of malnutrition. That's something known as prealbumin. It's a level of, again, protein in the blood, essentially. And it gives us a marker of what that child's been taking in over the last 3 weeks. 32% of our kids were either overweight or obese. And this is in comparison to the general pediatric population. 18% of the general peds population is overweight or obese. That's really high. But our kids, specifically in drug endangered homes, were almost twice as likely to be obese or overweight. And this is obviously from an excess of calories, but usually very poor quality calories as well. When you walk into that home in that photograph, you probably didn't see broccoli and cauliflower sitting on the kitchen table. If you did, there might have been bugs buzzing around it. What you probably saw instead were empty bottles of Mountain Dew and pizza boxes or McDonald's wrappers. So again, the quality of what's going into those bodies is probably very poor. And just so you know as well, when we look at our all of our children and study the laboratory evidence of malnutrition, a good number of our overweight and obese children also show evidence of protein malnutrition. So that just goes to show that they're getting a lot of poor quality excess calories. From a medical perspective, we identified 20% of our population did not have a named primary care provider. And there were also several others that maybe had a named primary care provider, but actually had not seen their primary care provider in a very, very long time. 70% of our kids didn't have a dental home. And I know some of you might roll your eyes and say that, well, dental care is really, that's an entitlement, that's really a luxury. Most kids who are on Medicaid, though, have access to dental in some way. Our health centers, our community health centers do have dental services in central and northern Wisconsin. So it is something that can happen. About 50% of our kids were poorly immunized and significantly deficient. And I actually didn't count any of the children who were just missing flu or hepatitis A vaccines, but these are, the 50% represents kids who are missing a significant number of their kind of the standard vaccines like DTaP and MMR and things that will help prevent vaccine preventable illnesses. So if these kids are lacking in their well care, do you think that when they have chronic conditions, they're getting what they need? It's highly unlikely. So why is this important? Without proper nutrition, there isn't enough what we call substrate for the brain to grow to its full capacity or its potential. If a child is battling chronic health problems, if they have chronic oral infection, if they have chronic gum disease, or other diseases or inflammatory diseases, infectious diseases, our internal resources will become focused on healing the body versus building the brain. So when we have these types of health obstacles, it portends to poor overall brain growth and function. So nurture are you guys seeing it? Uh-oh. Hold that thought. Okay, are we back on?
We are.
Okay, so told you, it shuts down on me. All right, at least it was at a good point. So, so nurture is likely one of the most important factors in ensuring a child's appropriate growth and development, and its value really cannot be underscored. When we talk about nurture, though, I'm talking about two main components, and the first is responding to a child's basic needs, so responsiveness to basic needs, and providing high quality, positive, nurturing experiences. So first of all, the importance of responding to basic needs, feeding, changing, comforting. It seems obvious to all of us here. Think about, though, what happens to an infant who is not fed in a timely manner, not changed when their diaper is dirty, or just not given attention. So for those of you who are parents, how did your children react when they were hungry? They cried, I'm sure. Some of them cry more than others, but crying is an indication of a stress or a threat. They're letting you know something's wrong, and then our job is to attend and to figure that out. And I'm sure in most circumstances, you, as the parent, responded really quickly. You fed your child, you alleviated their stress or their threat, and they stopped crying, and everything was good again. But what happens when that response to the cries is slow or non-existent? Like the children we discussed who experience unsafe living conditions, these children who have unresponsive caregivers actually develop an exaggerated stress response, because it isn't just it's not a one-off. It's not one time that they fail to respond. It's multiple times. It's daily. And unresponsive caregiving is actually perceived as a threat by the infant's brain. So the same cascade of events that we talked about with those unsafe conditions happens with unresponsive caregiving as well. Look at the photo here on this slide, and this is a dad who is, I keep forgetting the name of the fruit, I'm sorry, but he's peeling an orange for his infant and probably talking through that process. And this is a wonderful example of a high quality experience. And these are types of experiences that are a must for that developing brain. A child's brain grows and develops because of their experiences. Every sensation, internal or external, is an experience that leads to a neural connection in the brain. Two neurons begin communicating because of that experience. If these experiences are abundant and positive, the child will have normal growth and development of the brain. But if the experiences are predominantly negative or absent, normal brain connections can't occur, and this causes delayed and abnormal development. So even though the concept of nurture is less tangible, the effects of lack of nurture can be assessed. So medical providers like myself are uniquely positioned to address this through comprehensive history, physical, and developmental assessments. At the Marshfield Child Advocacy Center, we routinely screen for developmental delays, which would be a good assessment of, again, that nurturing piece. And we often see indicators in our patients of psychosocial neglect. When we look at the general population of children in the United States, about 13% of them, not a little more than 1 in 10, will have one identified delay. And when we look at delays, we look in there's actually 5 different domains, but they'll have a delay in one of those 5 areas. In our population, and these are screens that are done both by the caregiver, but then also through our assessment of the child, 75% of our kids had some form of developmental delay, and 25% had what we call global delay. And I define that as having identified developmental delays in at least 4 of the 5 domains. So almost completely across the board, we're seeing issues. Now, speech is probably one of the most important indicators of neglect. It's also a relatively specific indicator of neglect because speech and language can only emerge as a function of social interaction, okay? A child can develop gross motor skills even when left alone. A lot of the kids that we see actually have very well-developed gross motor skills. But children have to have audible interactions. They have to have interactions with someone that has speaking with them in order for them to learn and develop their own speech and language. And we've seen case studies of children that were raised in isolation with a hearing impaired or a deaf mother. And this child in particular had absolutely no speech when they were found at about 3 or 4 years of age. So again, it goes to show that speech can only occur in that environment where they're being spoken to. In our population of children, 34% of our kids had an identified speech and language delay, requiring referral to speech services. And again, this is between 2 and 3 times that noted in the general population. So the general pediatric population, they'll see maybe 10% of the kids will have a speech delay. But in ours, it's 34, 35%. And this is important because speech is also a marker of eventual intellectual development. Children who have speech and language problems because of that lack of experience, especially when they're not addressed early, likely have more learning impairments once they reach school age. They have more reading disabilities and problems with written language. They'll likely have poor overall academic success and lower IQ scores on testing. As adults, individuals who started off with poor speech, leading to poor intellect development, were more likely to hold lower skilled jobs and more likely to be unemployed. So again, portending to poor overall outcomes. Unfortunately, there is a critical period for speech development. Studies show that if appropriate interventions for a child showing speech delay do not occur before 24 months of age, a child is more likely to continue having those delays in both expressive and receptive language. So their ability to take in your words and evaluate them, but then also their ability to respond to you. So the importance of recognizing these children, recognizing children who are suffering likely psychosocial neglect, leading to speech issues, and again, eventual intellect issues, is so important. And the need for appropriate long-term interventions cannot be stressed enough. So neurobiology of adversity, right? This is again, how do these exposures affect brain growth and development? Okay, what do these do to the developing brain? Healthy brain development, like we've mentioned, is dependent on several things, including having the appropriate building blocks from that in utero experience and having positive experiences throughout childhood that support appropriate growth. In the DEC environment, as we've talked about, there are a number of potential threats, potential adversities that are going to increase the child's risk of having a negative outcome. And I'll just recap, when the fetus in utero is exposed to toxins, they may not develop appropriate numbers of brain cells or building blocks. This is going to limit the size and integrity of their brain structure. When an infant is exposed to toxin, it might alter the overall function at specific sites in the brain, like the memory center, the motor centers, the executive functioning centers. When there's suboptimal nutrition or medical neglect, when there's lack of medical cares, this alters the brain's capacity for growth and development as well. And when high quality experiences are absent, the necessary neural pathways can't be formed, limiting normal brain growth and function. The result from these types of experiences are many. First being behavioral dysregulation. This is the child who just can't control themselves, gets upset at little things and just goes off the handle. We'll see symptoms of inattention and hyperactivity. Unfortunately, these kids often get diagnosed with being ADHD, and it probably truly isn't an organic ADHD, but more of a function of their environment. We'll see developmental and intellectual problems, like I mentioned, but then also we'll see emotional problems like more depression and anxiety. When we add those scenarios that stimulate the threat response, like a chaotic environment, unsafe situations, other abuses, concomitant abuses, and unresponsive caregiving, we create a chronic stress response in that child's brain. Remember that the brain's job is first to keep them alive. It's to help them survive their environment. And when there is chronic threat, the brain will adapt to this environment by expecting and preparing for chronic threat. And what develops is that exaggerated stress response that's triggered by very trivial stimuli. What we see in these children are the hypervigilant child, the child who's always on guard, always looking for something, maybe misreading the cues that are out in front of them. Children that have an exaggerated fight, flight, or flee response, and that might come at you with aggression. They might run, or they might dissociate. So you might have the externalizer or the internalizer, the child that kind of disappears into themselves when they're stressed. And then also, again, memory problems, because certain parts of the brain that their role is to create memory, the hippocampus that I mentioned earlier, gets shut down when children are under significant amounts of stress. And overall, these kids have difficulty utilizing any executive functions if they were even realized. The saddest part for me is that these kids often get labeled as being bad. They are considered unfixable or broken. And because we love our labels in medicine and in our society, they might get diagnoses of ADHD, ODD, conduct disorder. And I've even seen some kids who have poor speech development get labeled as being autistic. They end up with a ton of medications on board as well. And it turns out that, you know, these types of treatments really don't help the child who has severe and chronic traumatic experiences. So I always like to throw in a little bit of art. This is JMW Turner's painting of the snowstorm. And to me, this kind of epitomizes what's going on in this child's life, the chaos, the storm of events. There's so much adversity, there's so much threat. And like this snowstorm, the results can be devastating and disastrous. Keep in mind that we are dealing with a snowball rolling downhill, okay? This problem is only going to get worse over time. And I don't just mean for the single child, but I mean for an entire generation of drug-endangered children. As we see these children grow from, you know, having behavioral challenges into dysfunctional adults, as many of them probably will, unfortunately, and they'll likely follow in their parents' footsteps in many cases. But remember that this is not their fault. And if we fail to recognize this, and if we fail to act on their behalf, we are part of the problem. So to tie this together, I wanted us to consider the definition of emotional damage in the Wisconsin state statutes. I'm sure most of you, if not all of you, are familiar with this, but emotional damage is the harm to a child's psychological or intellectual functioning and shall be evidenced by one or more of the following characteristics exhibited to a severe degree: anxiety, depression, withdrawal, outward aggressive behavior, substantial and observable change in behavior, emotional response, or cognition that is not within the normal range for the child's age and stage of development. When I read this statute, when I read this definition, it's almost as if this definition in my mind were written for the drug-endangered child, okay? Many of the things that we've just talked about are written into this definition. For instance, the anxiety that you can see and depression when we have neurotransmitter issues, the withdrawal, the outward aggressive behaviors from a child with an overactive stress response, changes in behavior and emotional response, and cognition, so the intellectual development is not within their normal range, age, and stage of development. So most of the kids that I see and that I've evaluated over the last 4 to 5 years have had at least one of these characteristics, if not more, and to a severe degree. So again, this is a real problem. Why then do I not see from my multidisciplinary team partners more petitions and more charges for neglect under this definition? Frequently, I hear from my partners that they've charged, my law enforcement partners, that they've charged, and they referred for possession or sale, but they didn't do neglect. They didn't look at neglect. And I get that there's multiple reasons for this. I also hear from my CPS partners that they weren't able to substantiate because they didn't feel that this seriously endangered the child's health and well-being. I disagree. These homes are, they're terrible. I've heard more times than I'd like to remember, and from some of our DAs as well, that this is just bad parenting and we can't do anything about that. But at what point do we hold our caregivers accountable for the lack of parenting that is so egregious that it contributes to maladaptive brain development that will lead to significant problems down the road? So trust me when I say that I'm not thinking that we have to incarcerate everybody. I don't think that we should remove every child. I don't think that we should not return every child. Not necessarily. I think every situation is different. But if we are going to give these kids a fighting chance, they need to be in an environment that can best meet all of their needs to heal. And let's face it, most of the caregivers who are providing care in these drug-endangered homes are not able to provide this. So what can we do? What should be done? First, for the child, obviously, removal from the drug endangered environment. That's a must, in my opinion. They need to be taken out of that unsafe environment, getting rid of all of those safety conditions. But that can't be where it ends. Placing them in high quality foster and kinship cares. Now, I know it's ideal, it's nice to put them with family, but sometimes that family member is just not the right placement and they are not able to provide high quality foster care. In fact, most of the times where I see placements not following through on our recommendations, it's a kinship placement. These kids need comprehensive medical evaluation with screening. And it should be done by an individual who really understands the drug endangered environment and what this does to the child's brain. That individual, that practitioner can then make more referrals. They can provide or they can help facilitate the interdisciplinary wraparound services that are designed to meet all of these child's needs, all of their healthcare and their behavioral healthcare needs in that new environment. So these are things like making sure the child has a medical home and a dental home, making sure that their medical cares are followed up on and their immunizations are all taken care of. It's making sure they get into speech services. They get occupational therapy and physical therapy services. They get other medical services that they need depending on their examination. And also helping to ensure that we are working with the educational systems. Because again, we have to make sure that the environment, that all the environments that the child is in are healthy and that recognize what's happened to this child. And the school system is a very important piece to that as well. And then something I would love to see is that we ensure, well, first of all, we ensure that the services occur. Many times I know our parents become obstacles to getting services, getting birth to 3 in the home or whatnot. But once those services are started, if the child is reunified, how can we ensure that those resources continue? The child isn't going to be fixed after 6 months or a year or 2 years. And we need to make sure that we give them every possible opportunity to heal. For the caregivers, and this is for any caregiver, so again, this could be the offending parent, this could be the kinship or foster placement, this could be the school system. Providing education that is, first of all, relationally based, that helps the teacher, the foster parent, the grandparent recognize how to work with the child. And also obviously to the offending parent, because we want them to learn probably parenting skills that they never had learned when they were growing up. And then finally for the offending caregiver, and these are all things that, you know, I know you guys are already doing and trying your hardest, but ensuring appropriate drug treatment for long-term sobriety, relationally based, again, behavioral health therapy. So these individuals need to work on themselves before they can even consider being parents, in my mind. Long-term surveillance. So things shouldn't end just because the family is reunified, and we have to continue to watch these children with this parent. And again, like I mentioned before, is ensuring that resources that have been recommended for the child especially, but also for the parent, are continued after reunification. I know we have a lot of our families, our parents, who kind of check off all of their boxes, get their kids back, and then fall back into all of the same bad habits, unfortunately. So in closing with this talk, I know that we all want to do what's best for our child victims in these cases. But simply going for the easy stuff like the possession and the sale is not going to accomplish this. When we only look for those aspects in an investigation, we are only seeing the tip of the iceberg. So again, our job is to first recognize the potential neglect in these homes, identify the children that have been exposed and the consequences from their exposures, and do everything we can to make that parent, that caregiver, accountable. Only then are these kids going to get the long-term comprehensive services and support that they deserve and that they absolutely need for healing. And that's it. Okay, Beth, are you there?
I am. Do we want to open it up to questions?
Sure.
Hi, this is Sarah Potter from probation. I just have a quick question. What would your response be to somebody who says, well, it's just marijuana and there might not be any issues there?
When you say somebody, are you talking about the parent? Are you talking about law enforcement or somebody else?
All people, like whether it's just the parent or whether it's somebody in the community who has an investment in this.
Yeah.
Such as social services, law enforcement,
Yeah.
there's been communication recently, that sometimes the views on the marijuana is changing because it's starting to be legalized in places. However, I believe it still poses a risk. So how do you respond to something like that?
And I totally, I hear that a lot as well. Marijuana is definitely a tougher one. Alcohol is actually kind of in the same realm in my mind, because alcohol is legal and marijuana will likely be legal. But know that marijuana does have detrimental effects on the young brain. It has effects on the adult brain as well and the adult body. It can cause actually some relatively severe physical health ailments, as well as other psychoses from the use, so brain ailments as well. So it is not without its risk. I think we have to be very careful moving forward, though, when as it becomes legalized. And if children are going to have significant exposure to marijuana, I think it should still be looked at. Considering that it's neglectful. Just like alcohol. Alcohol tends to, I think, get pushed to the side as well. Kids get put back into homes of known chronic alcohol abusers, and the level of neglect going on in that home is just the same as someone who's using methamphetamine. So.
I agree. Thank you so much for your insight.
Anybody else?
Yeah, this is Kate from Vilas. I just, I think in your closing, you talked about the long-term surveillance of these families, and I agree with that. I think we have to provide continuing support because habits form over a period of time, and they need to reform over a period of time. I think the difficulty that we have, though, from a legal standpoint, is that once families, like you say, hit all the check boxes and go through what they need to do to demonstrate to the court that they, have done everything, it's very difficult for us to hold the case open at that time. And I guess I'm wondering if there's other ideas on how and what organizations and how we can begin to, as a community, continue to provide that kind of surveillance or support, that's a better way to put it, but a way to stay in the world of these families.
I know we can't make 100% assurances, of course, but we had a recent situation where children were only out of the home for about 6 months. I think mom was only sober for about 6 months. And the children got placed back in the home and one of them died. And so I think that we have to do better. 6 months, in my opinion, is way too short. And obviously with methamphetamine especially, it's highly, highly addictive. So are there other resources that we can put into their home? Are there other, I know some counties have a special kind of, I forget what they're called, like the community response resources, but not every county has access to that. But are there other things that we can be doing to keep an eye on them, but also provide them with that help that they need? Because I think many times we want to say that, well, this is the parents' problem, it's their fault, they need to figure it out, they need to pick up the pieces. But that's so difficult to expect of them, I think, especially when they are dealing with addiction. So yeah, I don't have an answer. I think that would be something that, would be great to come together to figure out how we can respond as a whole.
Kristen, this is Tony. Sorry. I know that here in our area, we have the recovery coaches through the work that I know like Rachel and those folks do. But that would be, again, having those caregivers be connected with the recovery coach who's going to provide that long-term mentorship that they really need. And so I think that we need to focus more on having those Or even, you know, how can, I know that social services, you know, you guys are, you know, understaffed, extended in many cases. And, you know, are there any ways to kind of maintain those meaningful relationships without necessarily, you know, under a legal or a court appointed, you know, an appointed way? I know that, you know, I know that's challenging and difficult, but so that's where those recovery coaches, I think, would play a really nice role.
Thanks, Tony. Tony's actually my husband and one of our team members, but he is an education specialist and does a lot of work with our traumatized kids and parents. So thanks, Tony. That was great. Anybody else?
Do you have a list of the ACEs questions? I feel like when I've looked online in the past, they've varied. So do you have a list of the questions from like your graph that you?
I do, and we actually have an extended list. So we actually survey on 20 different questions. The first 10 are the traditional ACEs, which are the five abuses and the 5 household dysfunctions. And then we have a second subset where we look at other things like, you know, has the child been placed in foster care, or are they being bullied at school? And so, yeah, I can make sure that I get that to Beth, and then they can get disseminated out.
Thanks.
Mm-hmm.
I just have one comment. My name is Becca. I'm an elementary school counselor in Crandon, and I am with you 100% when it comes to the emotional damage and how frustrating that can be, especially as a counselor who witnesses it every day. And I think that is an important missing piece just for, you know, the other systems to know that as school counselors, we are there, the classroom teacher. We see these kids so much, you know, we see them every day. And we have so much information that could be helpful that, you know, just a reminder that we're here, that sometimes we're underutilized, but we know these kids. So I just wanted to comment on that.
No, thank you. And actually, I think that's a really great point. And one of the things, when we actually developed the trauma education specialist position here at our center that Tony's in, that was one of the things we recognized, is that how do we collaborate better with the schools, and how do we pull school personnel into educating, but also learning from you and learning from your experiences. And we have to change all of the environments around these children if we're going to really make a dent in helping them heal. We cannot expect the child to get fixed. That's just not how this works. We as the adults have to provide a much more nurturing environment, and that's every environment that they're in. So.
Dr. Braden from Tri-County. I'm just curious, with your with your experience, are you aware of any maybe non-traditional warning signs or red flags either exhibited by the caregiver or by the child themselves that could indicate something deeper that is generally overlooked?
Do you have something in mind, Braden? Okay. You know, I don't know of not non-traditional. I don't know that I can think of anything off the top of my head. I think you know, obviously all of the one slide that showed all of the different like manifestations of that. A lot of these kids will show 1 or 2, but many of them will show everything. And I guess one example, maybe to speak to this, is the child that dissociates more than acts out. They act in. So stress can cause some children just to go internal, but then that can get misconstrued by whether it's their teacher or their parent or the foster parent as, well, they're just being sassy. They're not responding to me. They're, you know, so there are other, I guess, less common manifestations like that. And Tony, chime in if you have more to add.
Yeah, I was gonna just say that. Yeah, I thought right away of those kids that are the internalizers, because they're not outwardly aggressive or outwardly, you know, but they're still gonna suffer academically. They're gonna stop functioning, maybe not at a severe level, but those kids, because they're not causing challenges, they very often go unnoticed. When I was teaching, one of the things, I had a really wonderful principal who logged like the contacts that I had with kids, and he pointed out this one student and asked me about this child, and I said, no, he's awesome. And he said, well, you only, you know, the 3 times I observed you, you only talked to this kid like once. you know, and so we, you know, we focus so much on those children that are causing those behavioral challenges. I think it's important to remember that there's a lot of children that are suffering silently, and we have to be more attuned to their needs.
So I probably should switch into the second talk just to make sure we have time, but I'm not exactly sure how long that talk's going to go, but we might have time at the end for more questions about this as well, if there are other people who do want, who do have some questions out there. Anybody need like a 2-minute break, potty break? Go take a 2-minute break. I'll just answer for you, and we'll be back, maybe just be back at 10:15, and we'll get started with the second talk. Thank you.
Sounds great, Dr. Iniguez.
Okay, are we ready to get started again?
Yes.
Okay. All right, I'm just going to jump right in. Let me turn my camera off real quick. Okay, part 2. So the other piece I thought would be really important to bring to this group was talking about the role of the medical provider. So hopefully you'll get some good information out of this one as well. And again, I have no relevant financial disclosures to make. And what I hope to accomplish in this talk, and I think I can pull it off in 45 minutes, is to first of all just review the concept of the multidisciplinary team approach to child abuse and neglect in general. But then identify the role of the medical provider specifically in drug endangered children's cases and the value that that provider's input can actually add to your investigations. Then we'll look at the importance of expert medical consultation and when it should be sought. And finally, we'll round out with the differences in and utility of toxicology testing in DEC, and that's probably what you're all waiting for. So first, the multidisciplinary team. We all do it, we all work together, but it's defined as that group of professionals working together in a coordinated and collaborative approach to ensure an effective response to reports of child abuse and neglect. And we've been doing this now for decades, and when it's done well, it's really, really a good thing for kids. It may not improve the overall outcome of charges and court cases, but it does definitely improve the outcome for the child, especially when we have that common goal for protecting the child and again, ensuring their overall well-being. And there are multiple benefits that can come from being part of a multidisciplinary team. And here at the Child Advocacy Center in Marshfield, we have, whenever we're doing a case, whether it's DEC or physical abuse or something else, we like to have our CPS, law enforcement, our advocacy agency, the medical piece, our forensic interviewer, all at the table, okay? And the reason why we want to do this is, first of all, there's less system-inflicted trauma. If we are bringing the child to that one-stop shop, okay, it's less likely that they're going to be interviewed over and over and over again. And we're not going to make them continue to relive whatever has happened to them. Now, I know DEC cases can be a little bit different, but we had a big case just yesterday, and there was a lot of very emotional information being presented by one of the children during her forensic interview. So this does apply to DEC cases too. There's enhanced information sharing and real-time information sharing. If we're all sitting around the table discussing a case, we're getting the most recent information at the same time, and then we can use that to synthesize and to put it together to really move our cases forward in the most effective way. I do think that having the MDT around the table also helps with improving decision making. Sometimes through those conversations, when we're all there together face to face, or however it is right now with COVID, we can talk through thought processes, and sometimes it can lead to somebody changing their mind from maybe they weren't going to forward charges, but now they are because of other information, and they've been able to pull out of some of the partners around the table. And it's an efficient use of limited resources. So we all are very, very busy, but if we can all come to the table one time, it might avoid having other conversations, other phone calls, other discussions, although that's always welcomed in our case too, because we know that things do come up. But again, it's ideal for you to be there to hear it the first time versus having to call somebody later to get that information secondhand. So. And then the use of the MDT is also so important, or the benefit, because I think that we all learn a little something every time we come together. We can all provide a little bit of education to our colleagues about what we do, and we can learn something from them to just improve our cases in the future. So. I also like to, from a community perspective, this also provides for improved optics when it looks like we are working together and we are, all on the same page, especially when things come out in the media, for instance, and we're all aware of what the others are saying, and it's very important. So when it comes to DEC cases, and really, honestly, for all child abuse cases, I hear the same questions. Do I really need a medical? But in DEC in particular, these kids often look normal. They look healthy. They look fine. What I showed you before in the last talk, though, is a lot of them have a lot of underlying kind of smoldering problems that you just can't see, like malnutrition, for instance. Or I hear often, too, that I just want hair testing. I don't want anything else. I don't need the exam. I just want hair testing. We hear that, well, we took the children to the ED, the emergency department, so do I need to get a medical evaluation with you? So can that non-expert practitioner provide an adequate evaluation? And then, wanting to just get that hair testing and be able to bypass this whole situation. Why can't so-and-so perform it? Why can't I just walk in and get the hair testing and be done with it? So I'm going to address each of these kind of as we walk through this, this talk today. So first of all, I think medicals are a very important part of any investigation that we do. There's so much you can get from the ideal medical evaluation. And when I say that, I mean that not every medical evaluation that you might attend is going to be the same or have the same quality. And we're going to talk about, who should be performing these in a minute. But one of the things that you'll get from an ideal medical, and that's, for instance, what I think we do here, is a chart review. So we comb for information about the child all over the state and sometimes all over the country. And we're able to put together, in most cases, a pretty good timeline of their previous medical care and what complaints they've presented with, what other injuries we've noted, what other problems they might have. we like to perform a really thorough medical history. So not only do we look at the medical records, we also talk to the caregivers, whether it's the parent or if it's a foster parent, getting information more so about kind of real-time complaints, what other issues they might be suffering from right now, and also interviewing the child in some cases about maybe what they've seen or what they've smelled or how they feel about the situation that they're in right now. Obviously, the medical examination is a key part, and that's where we might identify other injuries, for instance. And again, this pertains more to, let's say, the physical or sexual abuse cases, but there are times where our drug endangered kids also have marks on them. Again, these things go hand in hand, these co-occurring abuses. So we should never discount the fact that this child could have other signs of other types of abuse. And then we can document that in our record that then you can utilize in your paperwork. And I feel that, again, cases coming out of the CAC versus a general practitioner's office or the emergency department, the documentation is going to be much more specific for what you need. And then we also are able to perform forensic data collection. So I think many of us think of this as like the SANE evaluation or the kit or the exam portion for sexual assault. But also in physical abuse cases, we do things like collecting information, ruling out other medical disorders, essentially to show that the child's injuries, the bruises, for instance, were not from a bleeding disorder. And in the cases of drug endangerment, we look at nutritional information and we look at toxicology testing and other things to, again, provide information that is medical in nature, but is also forensically sound. Did I go backwards? Sorry, I keep hitting the wrong button. I apologize. There we go. One of the things that we employ as part of our evaluation is a standard protocol. And what that means is that every child that we see, whether it's for physical abuse, sexual abuse, or drug endangerment, we have specific things that we will look for in that case. So in the case of drug endangerment, again, we look for not only physical signs of abuse and neglect, we also look for laboratory evidence. So we'll do the nutrition screenings, we'll do all of the developmental screenings to put that whole picture together for the child and for this case. The identification of occult injuries and infections, that's kind of more around physical abuse, but still could be pertinent in drug endangered cases. And we can talk about review of mechanisms, but more specifically in DEC cases, we review, again, what the meaning of the developmental assessments mean for this child and what the exposures mean for this child. And as always, we provide a written report and then, if necessary, testimony. But besides these basic things from a medical exam, what else is it that we can offer you for these cases, or the child, and more importantly, the child? Many times we're able to identify and then provide treatment for other like unrecognized health problems. The child with poorly controlled asthma. I just had another case of a child who might have a muscle myopathy. And these were things that were missed by the pediatricians if the children had had time to go to their pediatricians. As I mentioned before, we make assessments for these developmental delays, and that's a big part of our process because, again, for drug endangered children, that is a strong indication of that psychosocial neglect. We assess them for nutritional status, as I mentioned, with those labs that we perform. And not only do we look at protein malnutrition, but we also look at levels of like ferritin, which is an indication of low iron. And we can help then provide the appropriate treatment to improve those numbers. And we also assess for emotional, behavioral, and relational problems. So by talking with the caregiver, talking with the child, we can look for any other signs of whether it's depression, anxiety, post-traumatic stress, if they're having difficulty bonding with their caregiver, the new caregiver, or their biologic parent. And again, very important, we can identify those deficits in care. So they may not have a medical home, they may not have a dental home. Maybe their parents didn't follow up on certain recommendations by their pediatrician, and that when we're doing that chart review, we find that information and then we can help fill in that hole. And so we do lots and lots and lots of referrals. As I mentioned in the last talk, routinely for kids from a drug endangered home, we're doing a behavioral health referral, we're doing speech, and many times we're doing occupational therapy as well. We're able to provide education to whether it's the biologic parent, the non-offending caregiver, or the kinship placement, foster placement, as well as other individuals who might be around the child. And then also providing reassurance as to the effects of the exposures these kids have had, and trying to reassure the caregiver that moving forward, the children are probably going to be, from a health perspective, okay, but we have to really employ a lot of these resources to ensure complete healing. So some key pieces of when should we get an exam? So one of the things we always talked about is children exposed to a methamphetamine lab, and again, that doesn't happen very often, but it still happens. Any child who is being pulled from a drug endangered home that has symptoms of COVID, symptoms of whatever, whether it's respiratory distress or fevers or something else, they should be evaluated promptly. Any child who has evidence or concerns for physical injuries, of course, they should be evaluated. Any child with another urgent or emergent need, maybe they're pulled from the home and they're on a load of medications and the parent didn't have those medications to provide. And so now we need to get refills on those. They should be seen. Any child with concerns for malnutrition, developmental delays, or behavioral concerns, they should probably have an exam. So in other words, any child being pulled from a drug endangered home is probably going to meet one of those criteria. And medicals are very important. And again, we'll talk later about the toxicology piece, but we can aid in the investigation, but we also aid in maximizing the child's overall health and well-being. So again, like I mentioned earlier, sometimes I hear that, well, the patient already had a medical, so we really don't need to get one. We took them to the emergency department or they saw their primary care doctor. We really don't need one. And what I want to, without, I'm not trying to disparage any of my colleagues from the emergency department, urgent care, or primary care clinics. I mean, they all are, physicians around the area are wonderful. We have for being rural, we have a lot of really high quality medical care here. But recognize that not everybody's training is the same. Not everybody's time is the same. So when you take a child into the emergency department, it's going to be a pretty quick eval unless the child is ill, because they don't really have the time or the capacity to do a very, very thorough developmental screen on that child. In fact, they don't have time to do a developmental screen at all. Primary care physicians are similar though, because they only have about 15 minutes. So unless we're able to book in a 30 to 45 minute appointment, they're just not going to have the time to do all of the things to assess the components that we need for this medical exam. Child abuse and neglect experts, myself, Dr. Nash, we're the two, I think we're the only two up here in kind of the central and northern region. We do have more training, we have more knowledge of the literature, we have more experiences with these types of children. And so I think that we really can provide an optimal type of examination. And Dr. Nash is out of the Wausau office. If you're probably more familiar with her than me anyway. And what I like to say is that, if you have a child, let's say with a urinary tract infection, you would go to their PCP, that's fine. But if you have a child with a much more complex medical issue like renal failure, you would probably not go to the PCP. Instead, you would take them to a nephrologist. And these kids in drug endangered homes are more complex. There are more issues here at hand. And so at some point, I think it is ideal for them to see a practitioner who has an expertise in this group of children. So this is the only study I think that I've got in this talk, so you're kind of off the hook. But this looked at primary care pediatricians' experience, comfort, and competence in the evaluation and management of child maltreatment. Do we need child abuse experts? So this study, they surveyed about 150 pediatricians about their abilities managing child abuse cases in general. And what they found in the study is that often the pediatricians, when they kind of scored themselves, they felt very competent in performing exams, but they really did not feel comfortable in rendering any kind of definitive opinion. So if it was a physical abuse case, saying that there was, that these injuries were consistent with non-accidental trauma, or saying that the history and physical was consistent with sexual abuse. And also the same would hold true for the drug-endangered child. They also, though, were very inconfident or unconfident in their ability to testify. So they can say things in their note, but when they're in a courtroom on the stand, it would probably, they would not feel confident in rendering any types of specific opinions. So expert evaluation, why should we get it? And training and experience, as I've talked about. So, I spend a good part of my week every week looking at children who've been pulled from drug endangered homes. So a lot of training and a lot of experience in this area. The confidence to be able to make these diagnoses and definitive statements, but also objectivity. I think sometimes the expert is able to get rid of some of those preconceived notions, those biases that many of us have, and be able to kind of step back and look at this, look at the objective pieces that are being presented to them. We have more time to spend. So again, the ED doctor is going to, unless the child's very, very sick, they're probably going to, it's going to be a quick visit. Well, maybe not a quick visit, but they're not going to spend a lot of time with the child. The PCP is going to have maybe 15 minutes, if you're lucky, 30 minutes. We actually spend sometimes upwards of 3 hours with our families. It's a bit ridiculous at times, but it's necessary. I think the documentation that you get from an expert, from a child abuse expert in particular, is going to be of higher utility. We're able to spell things out, I think, in a way that's a little bit more understandable. When we do see injuries, we are very specific in descriptions of those injuries. We don't just say, oh, there was a bruise on the leg. We tell you the location of the bruise, we tell you the size of the bruise, the color of the bruise, all of that. And the same with the DEC types of cases. We're, again, very specific in that information. And the nice thing about finding or working with a child abuse expert, especially here in this area, is that both of us are associated with Marshfield Clinic Health System, which is a tertiary care medical center that has multiple resources at our fingertips. So we have lab and x-ray here on site, as does Aspirus and Ascension, but then we also have other medical experts that we can bounce things off of if we have any other concerning findings. Excuse me. We have radiology specialists who are, again, second to none in the area. They doing a good job with reading any imaging we might get. We have access to toxicology experts here in our lab. And as well, we also have access to child life specialists, which, if you're not familiar, these are individuals that come in to our center during cases, and depending on whether a procedure is being done, whether it's a blood draw or something else, they really help calm the child and give that child a sense of safety. And that's something that most of the other systems, as far as I know, do not offer, for sure. And the last thing I think that I can have on my slide anyway is that we offer access to resources for the child and family. So at any of the visits here, and also I think over with Dr. Nash, there's usually an advocate from one of the local agencies that will be in attendance, and will be able to help provide other resources from the community on top of the resources that we're already offering. Okay. So I'm going to jump into the toxicology testing, which is, again, probably the one thing you guys really wanted to hear about. Excuse me. Hold on just a second. So tox testing is, I think, a really great adjunct to what we already do for drug endangered children. But it's just that, it's an adjunct. Testing for drug exposure does not replace a physical exam and does not replace any of the things that we talked about earlier with the needs of the child. The tox testing is able to provide us both medical as well as forensic information. So again, providing an evaluation that is medical but forensically sound. And so it will essentially hold up in court. So what the testing is able to do is provide us, in many cases, not all, but provide us specific identification of what exposures that child has. And that obviously can be used in the petitions or in the referrals for charges to support the overall investigation and support the fact that the child was living in a drug endangered home. But it's really important that we understand the capabilities of our testing. And not all tests are the same, and our test can't be used kind of across the board. I think we really have to be very choosy about how we are utilizing toxicology testing. And again, in addition to that is recognizing that we need somebody to be able to interpret the results of these tests. And we have to understand the true meaning of the results because sometimes that can be problematic. So we'll start by talking about the rapid urine test. And this is the very popular test that's done in the ED. So if you take a child into the ED, this is the test you're probably going to get. Now, it's a good test in that it can very, very quickly identify potential systemic exposures to toxins, okay? And when I say potential, because the information provided by the rapid urine test does not tell us definitively. Unfortunately, these tests can have a lot of cross-reaction, but we'll get to that in just a second. The urine test is very good. It provides us a 72-hour window of detection. So if you have pulled a child, you can take them into the emergency department within 72 hours to assess what types of significant systemic environmental exposures they've had. And when I say systemic, that means what's actually gotten into their body. We do recommend getting them in as quickly as possible and not waiting the 72 hours though. The rapid urine test will typically screen for those street drugs, usually the 5 or more classes, including amphetamines, cocaine, marijuana, opiates, phencyclidine, excuse me, and sometimes benzodiazepines as well. The issue with this test, though, is that it's performed by immunoassay. So that is an antibody test. And what it does is essentially uses antibodies to detect drugs or classes of drugs. But there is a lot of cross-reactivity. So an antibody might have an affinity for methamphetamine, but that same antibody might also have an affinity for medications in a Vicks vapor rub, which is true. So any testing that comes out of a rapid urine test is a presumptive positive. It is not an absolute positive, and it should not be used and cannot really be used in court. So again, beyond like Vicks vapor rub causes a cross reaction for methamphetamine, but also so do other ADHD medications and Zantac as well. And then I also had done some reading on this, in certain NSAIDs and even some baby wipes can cause cross reactivity for drugs like cannabinoids or marijuana. So the rapid urine test is great because it's quick. You can get it back usually within an hour in that visit. But there are a lot of challenges with it. So beyond the fact that it requires a confirmation, okay, that's big because remember, it's only a presumptive positive. It doesn't do as great of a job with synthetic drugs like fentanyl and oxy, for instance, and synthetic cannabinoids don't show up in it either, at least not the last time I've looked. And we really generally don't get chain of custody with this. So no one's watching the sample being obtained. There's no specific handoff procedures for the rapid urine test. comprehensive urine tox is a much stronger test in our cases for drug endangerment. It gives us the ability to specifically identify systemic exposure. Okay, so it's going to tell us pretty much exactly what drugs this child was exposed to. Again, like the rapid test, it gives us about 72 hours of detection. And again, I recommend if you can, you get them in as quickly as possible to get the comprehensive urine done. And it does test for a very broad range of drug classes and their metabolites. So again, a very good test. It takes a little longer to get back though, could be 3 to 5 days. But we actually do perform this one in-house at Marshfield Clinic. Well, some forms of the test we do, I should say. But it's performed by something known as gas chromatography mass spectrometry. Say that one 3 times fast. Or liquid chromatography mass spectrometry. And what this is a technique that actually breaks down the sample and analyzes it and gives us a very specific reading. So through chromatography, the sample is vaporized or liquefied, depending on which form, and it's broken down into its component molecules. And then through mass spectrometry, the molecules are then ionized, and based on the mass to charge ratio of the ionized molecules, it can determine what drug we're specifically looking at. So it's unambiguous identification, and it can differentiate amphetamine from methamphetamine, or other drugs that are similar in nature. So the challenges for this test, though, are that it's not offered everywhere you go. In fact, I had a case recently in Wisconsin Rapids where the CPS worker had taken a child into the ED. We had talked, she knew what I wanted her to ask for. She told the ED doctor, and he ended up just doing a rapid urine and didn't do the comprehensive. So a lot of places, again, don't offer it or don't necessarily recognize what the test is. That timing and collection for testing is also, can be a problem. So you're pulling a child from a home and maybe they're going down to grandma's in Madison. Well, it's going to be hard to get them back for a urine collection within 72 hours. And for some of our children who are diaper age, we have to do bag specimens on them. So we have to, they can't pee in a cup for us, so we have to obtain the urine in a more creative way. So we usually take the plastic bag around their genitals. So the cutoff values used in some of our comprehensive testing, you do again have to be careful. We at the clinic have a specific test for children and for drug endangered homes, but a lot of places might use actually workplace cutoffs, and those cutoffs, those values are higher than what you would see in a test for more passive exposure for children, for instance. And so it might miss a group of children whose maybe levels weren't higher than that workplace cutoff. And then again, chain of custody, we have to specifically ask for this to ensure that it happens. And to be able to present this information in court, chain of custody really should be performed. So this is a depiction of gas chromatography mass spectrometry. And you'll see, so each of these little waveforms that you're seeing on this time scale represents a different drug. And just to show you, so this is where amphetamine would be located on this scale. And there's methamphetamine, Sudafed, Molly, and ecstasy. So again, every drug can be determined in an unambiguous way. Okay, it can be very specifically determined. Sorry, I'm going to go on to the next slide. Okay. So I want to talk about hair toxicology. We perform a lot of hair tox. We also are doing the comprehensive urine tox, but we have difficulty getting our kids to us within that 72-hour window. So hair toxicology is our go-to. I know my colleagues down at Milwaukee, who I think very highly of, don't do any hair testing because they basically say that you can't place the child in the environment using hair testing. And I would argue that you also can't place the child using urine testing because you're still getting 72 hours of exposure. But Hair Talks has a lot of really good added value for these cases. It gives us the ability to identify, again, specific exposures, because it does also use gas or liquid chromatography with mass spectrometry. So again, we get that very specific determination of what drugs the child has been exposed to. It has a window that is 7 days to 3 months prior to when the hair was taken. This is not a hair follicle test where people think we're not actually pulling hair. It is a hair shaft test where you're cutting the hair at the level of the scalp. And most hair testing that's being done is hair shaft, not hair follicle. We just call it the wrong name. But because it takes time for the hair to grow out, so let's say a child was exposed to meth on Sunday, it takes until the next Sunday, roughly, for enough of that hair to grow out to be able to be sampled and then utilized in the testing process. But the wonderful thing too is we get a lot of historic information. We get that 3-month window, which tells us, especially if we have urine to go along with it, that shows that yes, the child was exposed in the last 72 hours to meth. If we also have hair testing done at the same time, we can also now definitively say that the child was also exposed to meth prior to them being withdrawn. And again, Hair Talks tests for a broad range of metabolites. We work with the US Drug Testing Lab out of Illinois, and their testing, we can look at up to 19 different drug classes and with multiple metabolites within that. So the challenges for hair testing are also the location, just like the comprehensive urine. And just so you know, Marshfield Clinic, we are working with lab right now to get every facility that has a hospital associated with it will be able to do hair and urine comprehensive tox testing. But then we're also going to be adding in a couple of other sites. I think Minocqua, Stevens Point, and Wisconsin Rapids will also be added into that. So we'll have the capability to do this testing throughout central and northern Wisconsin. Another downfall with young children when we're doing hair testing is having enough hair. We just had a little guy brought in the other day, and unfortunately they didn't call us in time to get urine, and he did not have enough hair. So basically we were only able to test for one drug class, and it wasn't the drug class that I wanted them to test for. So he'll have to, hopefully in 3 months, he'll have more hair and we can actually test that. And again, chain of custody is a must with this, and you have to have individuals who are trained to do it to be able to perform that test in the appropriate way. So this is a picture from US Drug Testing Lab's website. And so again, we generally use their Child Guard panel. And keep in mind that any type of comprehensive testing for drugs is an expensive test. Most of our kids have Medicaid. So it does get paid for, and that family won't receive a bill. But if the family has commercial insurance, they will probably receive a bill, and it will be quite expensive, especially depending on the panel that we use. So we almost always start off with the 5 panel, and you can see that it tests for amphetamine, cannabinoid, cocaine, opiates, and phencyclidine. But in some cases, we can actually add things on. So we had a big daycare case a year and a half ago, where the babysitter was giving all of the children Benadryl to make them go to sleep, and there were a lot of other bad things going on. But this lab was able to add on a Benadryl test for us as well. And they just started adding kratom, which thank goodness we haven't seen a lot of in this area, but it's a pretty awful synthetic opiate-like drug. The one thing you should know is that if you're looking for anything more specific like fentanyl will not show up in our opiate classification. So if you do have a child that you're really sure that there's fentanyl in the home, we'll have to let the lab know that and do a different panel, because we can get it. It's just not offered in the 5, 7, 9, or 10 panel for the drug, for the Child Guard. So I always really recommend proceeding with caution. And when you're considering drug testing for a child, it is good to talk to somebody who has the experience with the testing and with this population. So again, a child abuse expert or somebody who is, again, just seen a number of these cases. So the first question is, who should be tested? And the one thing we really try to avoid here is that, we're not going to test any child off the street. We want to make sure that these kids are being, if we're going to test them, they have to have a known association with that type of toxic environment. So usually our kids are coming out of homes where a search warrant was completed and drugs and paraphernalia were found. Because sometimes we might get results if we're just doing random testing that we don't really know what to do with, and we don't want to put ourselves in that predicament. And when we test the children that are directly pulled from an environment, especially when we know that there was confirmed substance, all we're doing is connecting the dots. We're basically saying that, well, that environment had meth in it. This child tested positive for meth. The likelihood of them being present in that environment where their parents living is very, very high. So we can place them in the house where we already found the drugs because their hair testing came back, or their urine testing for that matter came back positive. But the one thing we don't want to get into is having mom coming in and asking her pediatrician to test the child because it's a custody issue and she thinks dad's smoking pot or whatever. And we do have that. So we actually, within the clinic system, we limit who can order this test because we don't want it to be a free-for-all. We also have to be very careful with the interpretation of the results. So again, that timing of exposure is so important. The urine test is going to give you that 72 hours, but the urine test is not going to specifically pinpoint where the child was. They might have been in 3 different homes in the last 72 hours. Okay, so again, I will never say in my documentation that they were absolutely in that home. I will just say that they were in an environment where they were exposed. The route of exposure is also cannot be determined by hair testing specifically. So another thing I'll say in my notes is that I can't tell you if the child inhaled it. I can't tell you if they ate it, if they absorbed it through their skin, or if they just walked through a room and held their breath and it got stuck to their hair, which is another potential route of exposure. So we do have to be careful with that. We can't make any assumptions. And I've been told in the past that staff from other places that perform this testing have said, oh, well, the child was is positive for, what was it? Native THC. That means they ate some pot. And it's like, no, it does not mean that they ate pot. So please, when you hear things like that, just, hopefully a little question mark goes up in the back of your brain that maybe that's not quite right. These tests cannot give us really dose of exposure as well. You'll see numbers in the lab testing, especially in the hair testing, and those numbers are arbitrary. We really can't tell you because we don't know how many times the child was exposed. We don't know how much drug was, whether it was in the air or whether it, again, was residues they picked up off of the counter or eating something that was contaminated with the drug. So we will not be able to give you a dose of exposure. The only time this might be helpful, and I didn't even talk about blood testing today, but when you have a child who dies and you do a blood test for toxin, that might be able to help determine whether it was a toxin that was found that actually led to the child's death. And again, we have to be careful with the metabolites that come back positive on testing. We want to make sure that we are making the appropriate determinations, okay? Just because heroin was found in the home doesn't mean the child is going to test positive for heroin. So if we see only opiates coming back positive or morphine coming back positive on a drug screen, the toxicology testing, we cannot say that this child was exposed to heroin for certain. So let me just show you. So for instance, codeine, if codeine is ingested, when it's metabolized in the body, it breaks down into norcodeine and morphine. Heroin also will break down to morphine, but then something known as 6-MAM. So the only metabolite that's specific to heroin is 6-MAM. So we have to see a child positive for this to be able to say that they were exposed to heroin in the home. Hydrocodone also breaks down to norhydrocodone and hydromorphone, which is also what dilaudid is. So we have to be very careful with what types of determinations we state based on the results of this exam. Methamphetamine is a tough one. Now, if you have a urine test, again, urine is telling you that the child has somehow gotten it into their body because they're peeing it out. But hair testing is a little bit different. especially when we're using the child guard testing, because they are not pre-washing these samples for children. When they're working with adults and they're looking at workplace tox testing, they do wash the samples because they want to remove any possibility of just kind of casual exposure, like again, a person being at a party where someone was smoking pot. But for children, we really want that passive exposure, so we do not wash their hair samples before and after. So when we're looking at methamphetamine, many times what methamphetamine does is it breaks down to amphetamine and methamphetamine. So unfortunately, this can be misconstrued as a, if we don't see both of the metabolites, we won't be able to tell you that this is more of a likely systemic exposure versus just, again, absorbing something that was out in their environment instead. Cocaine also breaks down into multiple metabolites. So we have benzoyl gonine, cocaethylene, cocaine, and norcocaine. If we see any of these, we know that the child has had a systemic exposure in some way, because cocaine that's being smoked doesn't break down into any of these. It only breaks down once it's inside the individual's body. Oops, I'm almost out of time. I'm gonna hurry, guys. So an ideal medical timeline, when you're pulling a child from a drug endangered home, what I would really like to see is that within that first 24 hours, a center like ours that's equipped to provide comprehensive services is being contacted. And ideally, what that center should do, and what we like to do, is we get labs very quickly. We'll have them go to any center that we can find that performs comprehensive urine tox testing, hair tox testing, and other labs as necessary. Because again, if we get that urine right away, we can say that, okay, there has been an exposure in the last 72 hours. But if we also get the hair testing at that same point, we know that there's been an exposure that was at least 7 days old, if not 3 months old. So now we have multiple exposures, and I think that's helpful for our cases as well. The child should then have some form of medical evaluation, whether by a general practitioner or by an expert in the next few days. And if they didn't have an evaluation by an expert who can look at their development and all the other pieces, they should be seen by somebody within 2 to 3 weeks if you have access to that individual or that type of individual. Okay, super quick. I wanted to give you a case or present a case that we just had a couple of weeks ago, but this is, I think, goes to show how this can be done really, really well and can really help a child on many levels. So we had an 11-month-old male we were called about that they wanted to get in to be seen pretty quickly. Mom and dad both had had prior methamphetamine addictions, and they both had recently been released from prison. Mom actually had been pregnant in prison and had been on, actually had been in treatment at that point because she was on Suboxone. Dad, around the time that we got this phone call, Dad had just been arrested and found to be in possession of meth on a quote unquote routine traffic stop. Don't know what that means. Mom was then also arrested a few days later, also in possession of this time meth and heroin on a traffic stop as well. CPS was notified the following day, and they had to go looking for the child because the child was not with Mom when she was arrested at on the second traffic stop. But the infant was then found to be in the home of known methamphetamine users. So was placed, obviously at that point, with a relative, and then brought in to see us the following day. So we now have contact with the child in less than 72 hours, and we're able to do a number of things. So first of all, our chart review. We found that the child actually had had a 3-week NICU stay and had gone into withdrawal, essentially, and was noted to have Suboxone on cord blood, which I think they already knew because Mom had been in treatment prior to her delivery. But also this child was known to have an abnormal echocardiogram. And then when we looked in the chart further, there was recommendation to see cardiology, and parents never brought the child in at the 6-month visit that they were supposed to. We also saw that there were multiple no-show appointments for this child in their primary care clinic. And I actually spoke with the primary care doctor, and she was able to confirm that. From a developmental perspective during my exam, he actually looked really good from head to toe. But this child, by both observation and by report from the grandmother, didn't use any consonants. So he wasn't babbling at 11 months, and babbling is a 6-month skill, okay? So probably not getting those experiences that he needs in his environment. He also was noted to not be really doing any rolling, no crawling. He could sit with a tripod, so meaning like he could sit with his hands at his sides and not fall over, but he did not look very stable. Oh my goodness, sorry, my transitions are all a mess here, I apologize. So we did labs on him at that point in time. His urine tox was actually negative, so likely in that home he had been with the meth users. There hadn't been too much going on at that point. But his hair toxicology came back positive for amphetamine, methamphetamine, benzoyl gonine, which is a cocaine metabolite, 6-MAM, which I mentioned was the heroin metabolite, cannabidiol, and native THC, which are marijuana metabolites. So meth exposures, coke exposures, heroin exposures, pot exposures. And remember, his cord blood was only positive for Suboxone. So he wasn't exposed to these things in utero. This has been since he was born. We also looked at his protein nutrition, and his level was okay. But his liver enzymes were elevated at 219 and 189. And we also do something called a creatine kinase, which looks at that muscle breakdown. And his level was almost 12,000, which was very high. The normal level is like 150. So, several times normal, which was a little concerning, more than a little concerning. He also had a skeletal survey at that time, just knowing of all of the different exposures he had had in that home. And there was a questionable buccal fracture of his lumbar vertebra number 3, which we're going to be getting a follow-up skeletal survey in just another week or two to confirm or to say that that was not a fracture. Oh my goodness. Sorry, I apologize. My transitions are all a mess. So this little guy had a lot going on. And if he hadn't been brought in, I don't know when some of these things would have been picked up on. But we did identify that he had not only speech delays and motor delays, but really global developmental delays. He had, from that cardiology, the echo that was done at birth, he had branch pulmonic stenosis and ventricular dysfunction that was never followed up on. He had this very elevated creatine kinase level, which could be related to methamphetamine toxicity, but we actually have already repeated it, and it's still relatively high. So it might actually point to a muscle myopathy instead. I think I mentioned that earlier. Those elevated liver enzymes. And of course, this is a drug endangered child, and he's also a neglected child. So we have a number of things going on here that are definitely going to affect his overall health and well-being, some of which were things that could have been prevented by his biologic parents, and some things that might be underlying organic issues. So we made several referrals for him. Obviously, he is going to be seeing his primary care provider. We've already talked with her. He's going to be going into speech therapy, physical and occupational therapy. He'll be getting a cardiology follow-up to get another echo to evaluate that heart problem. And then because of these muscle myopathy concerns, he'll be seeing neurology, genetics, and gastroenterology services as well. Okay. So in follow-up, sorry, I'm done. Really what I'm hoping to convey to all of you is that you should have a low threshold for obtaining medical exams. There's so many reasons when kids are being pulled from drug endangered homes to do it. And they can provide critical information both to enhance your investigation, but as well as to support the child's overall health and well-being, which really should be our kind of ultimate goal. Tox can be an adjunct to the medical information that we provide, and it really can provide strong support for investigation, but know that it has its limitations, and it really should be used cautiously and with expert consultation. All right. Sorry for going over. I am done. And I'm sorry about my slides. They got a little messy there at the end.
So do we want to take a few questions?
There's a question in the chat saying, what is the difference between carboxy THC, native THC, and delta 9 THC?
Great question. And what I usually tell folks is not a lot. It's all indications of marijuana exposure, and it's just one of the many breakdown products of marijuana. So if it's coming back positive on that result, it's an indication that there's been marijuana in the home or whatever environment the child's been in.
But it doesn't tell us necessarily how that child ingested or was exposed to?
No. That's a limitation of all of our testing. It doesn't really tell us the route. So.
Other questions? You guys can put them in the chat, or looks like there's another one. Is there any quantitative interpretation of hair testing results? And I can't read the rest of it, Carrie, if you can.
Yeah, it says, is there any quantitative interpretation of hair testing results, as in a higher number represents a greater aggregate exposure?
No, like I said, we really can't use that. That information is arbitrary, because with that hair exposure, you don't, and even with the urine for that matter, you just don't know how many times they were exposed to it, what the dose of the exposure was. So there's not a lot we can do with that at this point.
I have a question. If we have a child that may be placed like in foster care, but is still having visits with the parent supervised, and still the parent is still actively using, and maybe they're sweating or something, I mean, could the child then still keep testing positive on a hair drug test?
Theoretically, yes. I mean, sweat is an issue as well. So again, that's one of the potential routes. It can be oral, it can be inhaled, it can be absorbed through the skin. And if the parent is sweating it and the child absorbs it through their skin, it's the same concept as absorbing a residue. So theoretically, yes.
I could just see that being an issue if we have a foster home that we know is, you know, not drug using, but then for some reason the child's tested and then they're still positive years later, I guess.
Yeah, and we don't do a lot of serial testing on these kids unless they go back into the home and there's another problem. So it's not like we're going to test them and then we're going to test them again in a month. The utility on that, I think that's part of the problem, is you might open up a whole can of worms there if something else is going on, or if there, you know, some circumstances like that. So it's not something that we would routinely recommend.
Another question is, what do you suggest for a young child that tests high on THC in this world of it's just marijuana, as far as them remaining in homes?
Sorry, I know that's a really hard one. I know it stinks, because like I said earlier, marijuana does have its effects on the child's brain as well. But it's, you know, it's kind of up to our DA's offices at that point, or, you know, with those, either with the petitions or the charges, what they're going to do with it. You can still do it, and you can still push for it. And we do say that marijuana does affect the brain as well. And you can also see the same neglectful effects in that home. But then it's up to then the people making those final decisions on what actually happens with the case. And I think it's going to take education to help them understand that, again, people using marijuana can also be just as neglectful as an individual using methamphetamine, or just as abusive, or, you know, there's a number of things that can go hand in hand with that. So I know that's not a good answer. I'm sorry. It's just, that's a tough topic.
Any other burning questions? All right. If there's nothing else, I want to, on behalf of all of us, I guess, thank you, Dr. Inigas, for spending the time. It's been very informative and great for all of our partners to be able to hear this information. We are scheduled for a lunch break from 11 to 12. I think we'll do 45 minutes. Kate, if you want to jump in here.
Yeah, that sounds good. So I know we've got Mike on, has been on this part, and I'm sure Danielle is going to be joining us if she's not already with Mike, but they'll be coming back. They're scheduled to start at noon. So we'll give everybody a chance to get a bite or do something else, and we'll see you back here at noon.
All right. And thank you again, Dr. Iniguez, for taking the time
Thanks
to.
for having me. I hope you guys got something out of it.
So Beth, is the plan to end this Zoom and reopen it up at 12 or?
If that would work easiest from a tech perspective is to just have everybody log out and then log back in at like 5:02, that works for me.
It doesn't matter to me either way. I just want to know how we want to do it so everybody knows what to do.
Okay. Oh, Kate, you're muted.
We'll close out for now, and we will jump back in, have everybody know that we'll be back open at about 5 till noon.
All right.
All right, bye-bye, everybody.
Seth and Kate, can I talk to you for just a second? Before
Sure.
Okay.
Other than the drug exposure, we kind of had to change things up prior to them adding this. I believe it was 2 or 3 years ago they added the G part of the child neglect statute or criminal statute to include exposure to either the manufacturing of controlled substance or controlled substance analogs or drug abuse. That really opened up a lot of doors for us and really helped us on the criminal part for charging options. And what it really did was solidify us working together with Human Services, as we'll explain here further. But there was things that the Human Services were able to do that would really help us in this, and then our work in law enforcement to really help their case. So this really was a turning point for us. It should be noted that, and I'm not sure, sometimes what we do is we ask everybody to type in where they're from. So I'm not sure if there's law enforcement here as well. Maybe somebody can give a head shake or not, or is this all just social workers? I don't remember what our audience was today, but if law enforcement should indicate in their reports that the child is a victim, because what that does is that opens up some options as far as the crime victim witness end of things through the state for funding for future help with the child. So we bring that up, and I'm glad. It looks like there's a few people here that are typing that out. If you wouldn't mind going into the chat section and just putting where you're from, just so we're aware of kind of a little bit better of the audience here. We got a few folks here that are doing that. We really appreciate that. That really helps to make sure that I try to cover all the angles of what your background is. So looks like they're pouring in now. Perfect. Thank you very much. And I do see at least there was one law enforcement officer on there, and so I'm glad that we have a good diversity. So our traditional child neglect statute is here, and what that is the failure to take action with necessary care, food, clothing, medical care, shelter, or education. What's important to know about this statute is that when we're doing the investigation, both criminal and through social workers, it's imperative for us to not only prove that that the kids were exposed to drugs, but I think it's also necessary to check into all these other components of the child neglect statute, because in all reality, we should try to paint the biggest picture that we can, not just the drug exposure. It really goes a lot better with the criminal case if you have any of these other components added to it. And it certainly helps the social workers investigation if we can recognize these components as well. So again, provide as much evidence as possible. Look at your statutes, know what you're working with there, and then add on to it as much as you can. And that comes in, the necessary care in medical care really is just good interviewing. And that really helps to look at the background, what mom or dad or caregivers drug history is, what choices they make, and you know what the impacts are because of their drug usage, and also show the both ends of the child neglect. So for example, we had a couple years ago that we will briefly talk about interviewing here shortly, but Danielle and I are doing an interview of dad, and Danielle gets a text message from one of the other social workers on her team saying, ask about Jenny's UTI. And she showed me the phone, so I knew to ask dad about the UTI. And so I asked dad, I said, you know, what's going on with Jenny's UTI? And he kind of looked at me funny, but he knew that I knew what I was talking about. And he said, yeah, she's had a UTI. I believe it was like 3 or 4 weeks that she had it, and it was untreated. And so when I asked him about that, he told us that they had gone down to La Crosse and were going to her doctor's appointment, but at the doctor's appointment, it was too much of a wait. And he admitted, he goes, I got impatient. And at that day, it wasn't bothering her as much as it was before. And so he made the decision for them to leave the doctor's office. And then he said he came back home. So during the interview, when I asked him who his source was for his meth, he had told me where it was at, and he had said that the source was down in La Crosse. And then I asked him, I said, well, when was the last time that you re-upped or went and bought more meth? And he had told me that same day as the doctor's appointment. And so I recognized that, and I had asked him, and I said, wait a minute, I'm confused. So last Thursday you went to the doctor's office and you went and re-upped? And he said, yeah. I said, well, when did you go? And he goes, well, I guess we left the doctor's office and I went to my guy's house. So not only did he take his kids there, but he also, didn't provide the necessary care for the child because he left the doctor's office instead and went and purchased more drugs. So those are all things for us to add into our report, but then also additionally, more resources for human services to take care of that as well. So I don't know if Danielle stated this in the beginning, but we do not allow heroin in Buffalo County. We won't allow them to use it here. So, and I say that jokingly, of course, but we, for some reason, don't have a lot of heroin cases. It's kind of all around us, but we don't have a lot of heroin cases here. So I will tell you that during our presentation, I'll reference meth probably 99 or 95% of the time, just because those are the cases that we're dealing with. Coincidentally, I mean, we had 2 DEC cases last night, and we're working on another one today. So meth is definitely keeping us busy. And so that's why our discussion most of the time focuses on that. And I would have a feeling, based on what I know of your area up there, that certainly both heroin and meth might be a topic or part of your cases, but I think meth is probably the number one driving substance up there that I'm aware of, I guess. So things to keep in mind about meth is that the children could be impacted both by airborne, the smoke, but also the surface areas. So any hard surface may have residue on it. Any carpeted or any material surfaces, those can all absorb and contain meth residue. If anybody's curious about that, there's a Thornton, Colorado study. I think if you type that into Google, you'll see it. And what that was a hotel room that they did surface testing in after a simulation of meth being smoked. And it's pretty interesting study and pretty interesting how they did that. But just one time meth use in a hotel room, if I recall, showed that the surface areas in there were positive for meth. So certainly the number one concern. I don't really think, I mean, we've got some parents that probably shouldn't be parents, but I really don't think that there's too many parents out there that are literally blowing meth smoke into their child's face. I'm sure they're out there, but 99% of the time it's, parents or caregivers that are using in the house, and that the residue, that the kids are being impacted by the residue. We do hair follicle testing and urine testing. I don't know that I need to cover that. The testing process, I think the doctor earlier covered that process very well. So I'll stay away from how that actually works. But basically, we use the law enforcement uses the hair follicle test to show the exposure, and then so does human services. So again, by working together, you know, they have those resources that we don't, that law enforcement doesn't, and so we utilize the hair follicle testing in all of our DEC cases. And obviously, depending upon the drugs, the health results may be different depending upon the kid. And Doctor earlier did an excellent job on speaking about that as well. So reports of the drug endangered child come through all different facets, but you know, certainly through our dispatch, certainly through the Human Services Office, but you know, observations at the home during, let's say, a domestic disturbance, or you know, a traffic complaint or impaired driver, EMS calls, general drug complaints. I mean, they come in all shapes or sizes. It doesn't have to be, hey, there's kids and drugs at the house. You know, it can come with, you know, like I said, the domestics, disorderly conducts, sexual assaults, child neglect, child abuse, any forms of calls where you're in there. You know, we have to keep an open mind that these calls can come in at various shapes or sizes. So how does the DEC program work? It starts with the report, obviously, you know, coming in from different entities, but it's recognizing it initially by law enforcement or human services that, hey, this is a drug endangered child situation. And then how do we change our response to get the best investigation that we can out of it? So when I say that is like, when you're at a domestic for law enforcement and all of a sudden you recognize that there are drugs there and there are kids there, it's to know that now I have to change what I'm doing and switch this to a DEC investigation rather than the standard domestic investigation. It's for human services workers to recognize that you were at a child neglect case. Now you're there walking through the house and all of a sudden you see a meth pipe. And now how do you, what steps do you take, you know, to further that investigation? If you're, you know, a social worker, do you exit and call law enforcement the next day? Do you stay in there and call law enforcement right away? Or what's your protocol, or what's your setup? What's your response going to look like given those situations? And that's all stuff that that your counties need to develop. If you don't, is how you're going to respond to those. You know, what actions you're going to take. Because if you don't have that all set up ahead of time, then mistakes are going to be made. And so that's why I think it's critical to get all that in an MOU and get that all put together, you know, earlier than later. And then once you've done the response, then what type of services or investigation are you going to do? And then what type of programming and prosecution are you going to follow up with? And those, you know, we travel from county to county, and I think that just about every county that we've been to is either planning or already does their DEC response, investigation, and programming / prosecution different. Everybody's got a difference of, you know, what choices they're going to make, and none of them are. Well, we've ran across some that have been wrong, yes, but most of the time, everybody's got good intentions. It's just a philosophy change that needs to be made, probably to blend those two together a little bit better. So why should law enforcement initiate a DEC response or elicit help from human services? The social workers have a number of resources that law enforcement don't. For example, the search warrant that we're going to do this afternoon. we're going to have probably 3 to 4 law enforcement there. We already know there's a kid there. We know there's probably going to be 2 or 3 adults. But we know that the child's there. So wouldn't it be in our best interest to contact the social workers right away so that they can start their investigation immediately, but also they can provide some help with law enforcement to take care of the 3-year-old child that's going to be in the house. I know, I mean, I've got 2 kids at home, but I know that when I'm in work mode and law enforcement mode, you know, I've got stuff that I need to investigate. And what I can't be doing is worrying about the taking care of the 3-year-old that's at the house. So, but the social workers, they need the interaction with the 3-year-old at the house. So why wouldn't we couple that? And then today, when we go there, you know, we'll have one social worker will be with me doing the investigation as far as inside the house. And then we'll have another social worker with the 3-year-old. And that social worker that's with the 3-year-old can start doing some initial observations of the child and start documenting, you know, needs of the child or how the child interacts, making sure the child's safe and doesn't need medical attention immediately. And so what that does is it takes a little bit of the responsibility away from law enforcement as far as worrying, what are we going to do with the 3-year-old and a search warrant? But it also starts the process up for social workers right away. So the social workers have the ability to access the EWISAQUIS, which is the second one down there. If I think I pronounced that correctly. That's always a fun one for me. But if law enforcement doesn't know what this is that it's the reporting system for all the social workers in the entire state. So if a family moves or wants to evade Vilas County and they move to Buffalo County social workers can see everything that Vilas County did if they open up a case in Buffalo County. And so what that does for law enforcement is that I can have Danielle, once she's screened in and opened up the case, which we've done today, I can have her go and see if this family was in another county. And let's say that there's been a drug endangered child response to this family before. Let's say that a child 2 years ago spoke to a teacher about a marijuana grow in the house or mom and dad using meth, and that was documented by the social workers in Vilas County. I would now have access to that and I could put that into the search warrant for the house. So definitely a valuable tool for law enforcement. And then additionally, I could call you folks up in Vilas County and ask about prior contacts that you guys had with this family and maybe add on to the case that we're working with. Law enforcement through Human Services has a quicker access to medical records. Once it's screened in, the social workers that are on here all are well aware of the access that you have to medical records. Once it's screened in, they can report that to the district attorney's office through their case. The district attorney's office certainly has that access with law enforcement. So that helps the law enforcement investigation if we have the dad who says that he has a UTI or that the daughter has a UTI, they have access to those medical records. The social workers have access to more money, you know, all kinds of shapes or sizes. When I look at Danielle, I always give her shit that the chairs that I have in my office are all from the stuff that they've thrown away. And so, but what it really comes down to with the DEC investigations is when it comes to the drug testing, the hair follicle testing, their budgets have the hair follicle testing built in. And so they're able to do the hair follicle testing where law enforcement can't or doesn't have the ability as far as financially to do that. So again, when we're working together here, there's stuff that we can do as law enforcement, there's stuff that social workers can do that really make one case that much better. And then I have child neglect with probation on here, but that is when there's a victim or the child neglect is a component with somebody who's on probation. you get a better reach with probation when there is a crime or a victim of the crime. So there's some frustration with law enforcement that when we bring in somebody for possession of meth, that they're not getting revoked or they don't spend any time in jail from probation. Sometimes probation recognizes that there is a victim in there, and sometimes that might trigger on their ramifications or what happens to that person. So another thing to keep in mind for law enforcement is, with probation with the child neglect statute. The other thing too is that social workers may have alternative results. There's times where law enforcement will go to a house and let's say the kid doesn't test positive for meth. Let's say that we don't find any drugs in the house, but the social workers may be able to provide services to that family and really ultimately stops their drug usage. And really, as law enforcement, that's what we're trying to do. We're trying to stop them from using drugs. And so if the social workers are able to provide programming to those folks to help them out, why wouldn't we try to do that? So now, you have that team aspect where you're both walking in the door and you're not just there to take them to jail, but you're also there to provide them services and ultimately protect the children, obviously. The most important part here is that everybody that's on this training right now, I believe, would be a mandated reporter. I haven't gone through the entire list, but I'm pretty confident everybody is, including law enforcement. And this is where I believe that law enforcement can really get in the most trouble and runs a slippery slope when not making the mandated report. When what we see a lot of times from our travels is that law enforcement isn't making the report to human services, and they're doing they're going out making contact, taking drugs, and then they're placing the kids somewhere else on their own, or not doing anything with the kids, and referring them for the caregiver for charges. And now that we're all aware that child neglect has the exposure to drug component to it, law enforcement really needs to be making the mandated report. We're all aware that drugs are dangerous. We're all aware that drug dealers are dangerous. Why wouldn't we consider that to be a mandated report to check the welfare of the children? And so we have the report within 12 hours, but in all honesty, it needs to be immediate, and these responses need to be together, not separate, not 12 hours. I mean, we've talked to counties that either aren't getting the reports or get their reports from the DA's office or get reports several days after the contact with caregiver and kids, and I feel that is not meeting the mandated reporter requirements, and really, frankly, could get law enforcement in a lot of trouble, because if there is something that occurs to the child and it's learned that there wasn't a mandated report done, that could be a heck of a predicament for law enforcement or any other mandated reporter.
Human services, in terms of the benefits that we get from collaborating with law enforcement, clearly on your screen, I don't need to read to you, but obviously access to the scene. As Mike's talked about our warrant today, we certainly have the ability to show up at homes, but if they don't want to let us in, then we have to make that safety decision for children with little information sometimes. And so law enforcement has other means of accessing a home or a residence and can include human services into that process. Here in Buffalo County, when Mike writes a warrant related to a drug endangered children response, he writes human services into that warrant. And so when that warrant is signed by a judge, our social workers have access to the home the same as law enforcement does. The other process would be the documentation within the home, taking photos of the residents, taking photos of the children, taking photos of the evidence that's been claimed if located within the home. Obviously, the simple one is safety of our human services workers. And so, as Mike's talked about, the danger to these homes, the danger in these homes, Social workers are obviously just increasingly safe if law enforcement's present with you. We exchange those in-house criminal records with law enforcement. So before we respond to a drug endangered children's program or home, we check our EWIS, we check what we have available to us, but our law enforcement's able to do a better check of their in-house records or just names of people. We're a smaller community, so certainly a little bit easier, but our law enforcement may know a family or know a name that the rest of us just don't have information to. We share a lot of training resources here in Buffalo County. We've tried to attend joint trainings when they're relevant to our jobs, but just as well exchanging our knowledge back and forth. So Mike does drug identification training for our social workers or our other people in Buffalo County that are entering homes, our parent aides and so forth. In the scene, law enforcement is certainly seeing things more frequently than social workers. So when we come across something that looks odd in a home, law enforcement can educate us on what that might be or why it's there or why it just shouldn't be there. Criminal arrest bond restrictions, we don't have that access. We certainly work with parents, but they need to be held accountable at times as well. So in Buffalo County, if a person is arrested following a response, a collaborative response with Human Services, our district attorney does make every attempt to include the compliance with Human Services and the children's case in any bond restrictions upon release. So that does help us, motivate parents to move forward to make progress in our cases as well.
So what should social workers and law enforcement be looking for? Clearly signs of drug use and kids. And my big statement is if drugs and kids are together in any shape or form, component, location, whatever, that's your DEC response, and that's where you need to start a change of the response that you were originally planning on. We're certainly looking for indicators of increased risk of abuse or neglect. We talked about that earlier, and then signs of actual abuse or neglect. The bruises or the reports of sexual assault or any of the other things that may be occurring. Not just the drugs in the house. But full circle. For those of you that don't know what meth looks like, there it is right there. I would highly encourage that if there's folks that are on here that don't know what drugs look like or drug paraphernalia looks like, to have law enforcement. I'm pretty sure we have a lot of ILS and it looked like Oneida County, but I'm sure that there is somebody in either one of those counties that would be able to provide a drug and drug paraphernalia identification class or course. And that would very much be beneficial for any of the folks that are on here, because if you're tasked with looking for drugs, you should certainly know what they are. If you're tasked with communicating with somebody that is using drugs and they're telling you that I'm buying an 8-ball a day, you should probably know what an 8-ball is, or a teener, or whatever various slang that they're using. And so that's important for a social worker to know, because they need to know that if somebody says I'm using a ball a day, that it's 3.5 grams. You certainly could ask the person, and most of the time they'll tell you, but it is nice to know and to be able to speak the lingo to these folks, because then they believe that you're on their same page and their same level. So if you're not getting the education on that, then please seek it. If Vilas or Oneida County Sheriff's Department or PDs aren't willing to do that, then call me and I'll come and do it. And I've actually done several counties now that for some reason they don't have a resource to do it, and so I offered and we did it. So by all means, if it's not there locally, please contact me and we'll do that. If you don't know what every item on this table right here is or what it's used for, you need to get additional training. Okay, this is all standard meth, heroin, anybody who's an injector, this is all standard equipment right here, if you want to call it that. So if you don't know what those items are, then let's get some additional training for you guys, okay? These are track marks. If you haven't recognized them before, here they are. They can be on all areas of the body. We've got arms and hands here, but I've seen it in ankles, toes, in the neck, anywhere there's a vein, I've seen the needle in it. So, all areas to be looking for. Burn marks, there's this gentleman here on the left is overdosed and he's got burn marks in the back of his throat. That's from the high heat off of a meth pipe. But you can also see that there's chapped lips on both of the subjects here. And then the picture on the left obviously isn't that great. That was before I started my professional photography business. But you can see his tongue has blisters, and that's again from the high heat from meth pipe. It's important to recognize that there's structural changes that occur when people are using drugs, and so I'm going to show you a couple pictures here, and I always have to put like the caution across here and saying, I'm showing you these folks here not to make fun of them or to degrade them, but there's really a learning opportunity to be had when you look at before and after pictures for a couple of reasons. One is that if you're a teacher, educator, or social worker or law enforcement, and you have contact with this woman here today, and this is what she looks like, then she looks fairly healthy. She is using meth at this time, but not as much as she will in the next photo. But what you look at here and what I teach in the drug identification class is that you look at the neck and facial features on the people, and 9 times out of 10, those are where you'll see the changes. The orbital or the eye socket will usually be sunken in. They'll lose weight. The fatty tissue around in the cheeks and orbital areas will change. Overall skin condition and complexion will change, and then there'll be a change most of the time in their neck area. And so if she's in your office today, but then 2 months later comes in like this, then we should start asking some questions on how much meth is she using. And as I stated earlier, you can see here that in the orbital area of her eyes, well, there's darkening that certainly helps, but you can see that she's losing the fatty tissue there. She's losing fatty tissue on the cheeks, and then her overall skin complexion is breaking down. Those are all things that all of us here need to recognize, that if there is this change, that we should start asking questions. Now, if this woman has kids, then we need to really start asking questions and probably get our DEC team involved. When I talk about earlier going to a call and then changing your response, this was a response that we went to for a domestic. And during the domestic, when I was there, I asked this gentleman's girlfriend, I said, well, he appears to be using quite a bit of meth. When has he started using again? And she said, well, it was a couple months ago, but he's really using heavy now. I said, well, what's the deal with his face? And she said, yeah, that's from a flathead screwdriver. And what he was doing is he was taking this flathead screwdriver and digging it into the skin because he felt like there was stuff underneath the skin when he was high. And so, again, we're not making fun of this guy, but what we are is we're showing the changes, and we're showing that these are things that we need to ask for and about, and we need to change direction on our initial. We could have easily just gone and arrested this guy for his domestic, brought him to jail, and not worried about the kids, easily, without asking questions or recognizing that there's a problem. And so it's advancing our initial response on these calls that aren't for drug endangered children on the initial report, and taking care of the kids. And so that's where it's our job to further those investigations when we suspect drugs and kids are together. These are your traffic stops with the baby on board. I mean, I teach drug interdiction as well, and I always tell the officers that are out there, listen, the baby on board, the Bible in the window, I've been sober for 8 months, placard or coin. Sometimes those don't matter. And certainly here in these cases is that, you know, these are two different traffic stops, and ironically, these happen like 2 months apart. But both had kids in the car and drugs. And so it happens on the traffic stops. It's not just at the house. And we need to recognize that these situations occur not just in the household and what you would commonly think is, you know, the report of mom or dad using at home and response. This was a traffic stop that we had. This was drug related. We were watching the house. We stopped the car after a suspected drug deal. And in speaking with the two guys that were in the car, we asked whose car it was. One guy said that it was a friend of theirs and that they were borrowing the car. Through more interview, the guys said that what they do is they come and they were buying, I think this was like a 1/4 ounce or a 1/2 ounce buy. And then what they were doing is giving mom a gram of meth for utilizing her car. But for those of you that have kids, and I use this analogy a lot, if you go to McDonald's and you get your kids a Happy Meal and you've got a 10-minute drive back to the house, do you have the kids wait and eat the Happy Meal when you get home? Or are they opening the Happy Meal at block 1 of your drive on the way home, and now you've got fries all over the back seat and ketchup and all that? This is the same concept could be looked at for somebody who's buying drugs. If you travel any form of distance, if these folks need drugs and they're coming to support their habit or their career, if you want to call that for drug dealing, 9 times out of 10, they're either going to be using at the house of their dealer or in the car on their way back home. That's almost always going to happen. Or, you know, nearest gas station or Walmart or dead end road, something where they're going to go get high right away. They can't have a bag of meth, or your kids can't have a Happy Meal in their hands and not want to use it immediately. That just doesn't happen. And so these guys are using meth on the way back to mom's house to give her the car. But what's also in the back of the car is 2 car seats for the kids. And so by them smoking and using it, they are exposing the kids to that residue on those kid seats. And so when they're in there, the kids are exposed to drugs. And so that's something that we really need to keep a open mind on, and again, furthering those investigations. So when we were done with this traffic stop, I made contact with the neighboring county and let them know that, hey, this woman's using meth and she's exposing her kids by allowing these guys to use her car. Is there kids here in this house? Everybody should look at the picture and say, yep, there is, because there's a Nerf gun behind there, right? This is the house of a guy who was high on meth. He thought there was people on the inside of his walls. We got called there for a welfare check because this gentleman's dad came home and found him inside. He was through that little hole there in the cinder block wall. He was underneath one of their additions and he was yelling and screaming. When we got there, we found out through interviewing that this was a finished basement. This was a finished room. And the guy was so high on meth that he thought there was people inside the walls. So he tore everything down. Would this be a situation where we should consider danger to the kids? Absolutely. Not only exposure to the kids, but what if the kids are down there when dad's tearing down drywall or tearing down the plywood off the walls or taking the plaster off the walls? All areas that we should be concerned about the kids. We could go there and look at the person, evaluate them, chapter them, or do nothing and do a safety plan and not be concerned about the kids at all. That's certainly possible. And patrol officers that are going to calls like this should be trained, and they should know that, hey, if there's drugs and kids involved, then I need to initiate a DEC response. The bag of rocks, if you folks don't have rock collectors up by you with the meth folks, then you're lucky. But we have, everybody is into rock collecting down here. I'm not sure what it is, but is this a danger to kids? Probably not. But is it something that, hey, if you're a social worker and you're walking in and there's bags of rocks all over the house and you suspect that they're maybe using meth, then you should know after this presentation that, hey, rock collecting and meth users oftentimes go hand in hand. I show the picture on the left is more comical relief than anything, but that is a operating wash machine in the driveway of a house of a place that we did a search warrant on. They were literally doing their wash outside in the driveway. Not sure why they weren't using their laundry room inside the house, but they just felt that that was something that would be better. So I think it's just funny. You oftentimes see these posts on Facebook, mom or caregivers, posting with the kids, trying to be the all-American family, but forgetting that there's drug paraphernalia in the same picture. That's something that that all of us, of course, I don't think you guys can utilize Facebook. Is that that's statewide? Okay. So social workers can't utilize Facebook for investigations, but law enforcement certainly can. And so again, working together, law enforcement say, hey, I saw mom and dad with their kid the other day, and you can see track marks on mom in the picture. You can see drug paraphernalia in the background. This is something we need to be concerned about. You might also recognize the background in Facebook pictures as being a hotel room. We see a lot of hotel rooms being utilized to for folks that are homeless or folks that are traveling to use meth or that are just utilizing the hotel rooms to party. And so for law enforcement and those that are able to use Facebook, certainly doing a background check on Facebook would be logical to see if they have kids, because oftentimes the caregivers are posting pictures with them and with kids on their Facebook pages. So evidence of DEC risk, this is what we're doing. This is our investigation. This is what we're trying to prove. Caregiver condition. Are they high? Do they look high? Are you looking at the before and after picture like I showed you? Is their skin condition, is their facial features or structure, do you see a noticeable change that through training and experience to be signs of drug abuse? Are the harmful substances, are drugs accessible to children? We'll cover a little bit more about that. During surveillance, are we seeing drug users come and go? Are we seeing sex offenders come and go? Are the social workers, when they're there doing the visits, is there other people there? Do you see other people staying in other rooms? Who are you asking? Well, who's the person in the other room? Well, that's Jim. What's Jim's last name? I don't know. I just met him last night. Well, why is he sleeping in your bed? Those are odd behaviors, not for people that are using drugs, because drug users hang out with other drug users, and there's oftentimes homeless people that are jumping they call it couch surfing. They're going from couch to couch to couch of other users. They go wherever the meth or wherever the drugs are at. And so when you're there as a social worker and you walk into that house and there's several people there, that's something that, hey, this is one, risky to you, but two, risky to the kids. The bottom line sums it up. Behavior and environment which poses risk to a child that has a drug component. That's it. If there's dangerous things that you see, if there's dangerous actions that people are taking around the kids, those are all things that need to be documented, need to be, photographed, videoed, whatever you have an opportunity to utilize to document it, you should. For law enforcement, if you think that somebody's high, run them through field sobriety. Have a DRE come out. If they're the sole person that's responsible for the kids, let's say that I know that doctor earlier talked about the child walking down the street in the diaper. We had a situation here last year where a guy calls and says, hey, I've got a little kid at my house that's the neighbor kid that can't be here. And our dispatchers further asked questions, and he said that, hey, I'm a registered sex offender. I cannot have contact with kids. This kid just showed up in my house, and I want the cops here because I don't want to get in trouble. Well, what we ended up finding is that mom had actually traveled, left the kid there home alone because the kid was sleeping, and mom was traveling to get her drugs. Now, what if mom was over there and she was nodding off from heroin? Or she had been using meth for 3 or 4 days and she was sleeping. Wouldn't that be kind of an imperative thing for us to show that, hey, mom was so impaired that she wasn't able to take care of the kids? Well, how do we show impairment? We have DREs, we have our field sobriety. We can certainly do that. Yeah, body camera, throw mom on there where she can't even stand. That should be excellent for court when she's supposed to be taking care of her kid and the kid's running down the street. You know, all of the training that law enforcement has and social workers, as far as, you know, prior cases that you've been to, prior experience with drug enforcement, undercover experience, all of those can play a role in the investigation. It plays a role in, for me, every time that I do my search warrants have my experience in undercover operations. It has experience in dealing with drug endangered kids and why there's a risk and why it's imperative for us to have the search warrant. That all should be in there and all can be put in part of your reporting. So if you're the investigator, you're the officer on the scene, it's your drug case. So obviously the social workers aren't going to be taking care of the drugs for you. That's pretty self-evident. But what we try to do is we have 2 officers respond to each DEC case. And so one officer is in charge of the drugs, evidence, the searching, and then the other officer, our DEC investigator, does the interviewing and the investigation as far as the caregiver's role in the exposure part of it or creating danger for the kids. So the officer that's on the scene that's taking care of the scene and the evidence part, you know, they document the initial at-risk parts. You know, if there's a light sockets out, there's meth on the floor or meth on the table, just those initial observations that you see that pose the risk. They're photographing, they're taking custody of the evidence, taking custody of the persons if needed, and then in their initial report, they're identifying the child as a victim. As far as searching, especially when it comes to a search warrant where you have a scheduled response, we'll, like this afternoon, myself and the social worker will walk through the entire house first. Before we do any interviewing, we walk through the whole house because they're going to identify things that are of danger that I may not, or that they may not. So let's get 2 different sets of eyes coming from two different views, looking at the house before we do any searching at all. All the rooms will be photographed prior to searching. That's one, to document the environment that the kids are in, but also to protect law enforcement from liability, to say, yeah, this was damaged before, or, you know, after, or while the cops were in there, like a TV. And we can show that the TV was cracked before we even went in there. Photo and measure anything that's found before it's moved. We'll go into that here in the next slide or 2. And then we photograph all the rooms when we're done. And again, for liability and just to show that there wasn't anything damaged while we were in there. The DEC investigator will take care of the interviews with the caregiver, also take care of any drug testing that needs to be done as far as urine testing with the parent or caregiver. So when we go there, basically our first line is I'll ask, let's say, mom, you know, if Kate and I go and we have contact, I'm going to ask Kate, I'm going to say, Kate, do you use meth? And Kate is naturally going to tell me no, because that's what they all do. They deny it at first. And I'll say, well, Kate, you know what? We got a report that that you're using meth and that you have a 3-year-old child here. What we would really like to do is we'd like to make things quick today, and we'd like to ask you to take a drug test for us. If you are clean and there's no drugs in the house, then we will be out of here just as soon as we can. And oftentimes what will end up happening is Kate will say, yeah, I'll take the drug test. I don't have anything to hide, because they don't want to admit to it, right? So then when we break out the drug test, and then Danielle is on the way into the bathroom with Kate, Kate will start crying, and then she'll admit to Danielle that she's been using meth for the last 2 years and that she needs help with her addiction. This scenario plays out over and over and over and over again for us. And so that's the way that we've done things, and it's been very productive in getting as much information as we can, and getting our foot in the door. We've also had situations where mom or dad have tested positive, we've gone there, they've tested positive, we don't have a search warrant. And then once we confront them about the fact that they have kids there and that this is a dangerous situation for the kids, then they've told us that we need to leave, which is fine. But at this point, we've got enough for the search warrant because mom or dad just tested positive for drugs, and that they have kids in the house, that we can write a search warrant for the house now because of the possible exposure to the kids based off of mom and dad or caregivers' drug usage. So it's really helpful to get that drug test in right away if possible. The DEC investigator will document the contact with substance, document the height and range of motion of a child. We'll go into that here shortly. Healthcare needs of the child, complete the forms, the DEC forms that we have set up with Human Services, and basically take care of any of the interviews that are done. Interviews with children are almost always not done now. I don't think that makes sense, but they're not done on the scene, and most of our interviews with any of the kids are CAC interviews now. We've transitioned from when we were first doing that, trying to interview kids. It's just not working, and there's a better way to do it, and that's through the CAC interviews. When I talk about the DEC investigator, if you're, I'm not sure that I don't know if we have any administrators like law enforcement administrators. I do know that there's some social worker administrators, but if you're in a situation where you're trying to get officers, law enforcement, or social workers designated as the DEC investigators, those folks that you want doing that are your best interviewers, are your best drug-minded people. So your drug investigator, your patrol guy who does good drug investigations, that does good drug interdiction work. You need somebody who's going to be able to talk to people and talk them into doing things that they don't normally want to do. What you don't want to do is have your officer that doesn't like doing interviews and doesn't like talking to people in an investigative capacity, because you won't get anywhere with the parents if you have that investigator or that interviewing doing it. Also, if they don't know, if they're not drug minded, we have several officers here that will tell me right off the bat, listen, I'm not really, I'm not involved in drug enforcement. I don't like drugs. That's just not my thing. Well, I'm not going to have that person as the DEC investigator. I'm not going to have them asking about their usage, about, how much are you using a day, when they don't know what an 8-ball is. That's counterproductive. So don't put that person involved in asking questions about drugs if they don't know, how drugs work and what the people that are using drugs do. They also need to work well with Human Services or social workers. If you don't have that good relationship together, if you're a guy who feels that working with social workers isn't a good idea, then you shouldn't be put in this position, because you need to have the team aspect or the team-minded person in charge of this type of investigation.
Human Services, so we take again, the 2 social workers out. So one to do sort of the drug identification, drug documentation. The other social worker is going to kind of sort of be responsible for the children's aspect. They'll be the ongoing caseworker. So if, the job from Human Services side is to make sure that we are documenting that living situation. Who's all in the home, who was present, what were they doing in the home? Obviously making that decision about removal if necessary, whether that be a TPC or a protective plan placement. Who's out there to take the children, making sure that those people are safe and stable. Responsible for the follow-up, so the physical health screening. We do try to do medical checks of the children within 48 to 72 hours following a response. Again, I kind of was mentioning earlier, we don't have a hospital in our county. We do have a couple clinics. So we do have to travel outside of that. So that time-wise is a little bit harder for us in our county, because we have to get that appointment and get there. We do hair follicle testing, and I won't talk much about that as Doctor did, but we do hair follicle testing on all children removed from a drug endangered children environment. So If mom or dad test positive or we find any paraphernalia or drugs within the home, we do automatically do a hair follicle. We have a facility that comes to us to do that, and so they come on scene or come to the placement home. And then we have the responsibility of making sure those kiddos have what they need when they're removed from the home if that's necessary. We, as a DEC program, have obtained a bunch of donations. So we have a closet here with clothing and hygiene supplies and blankets and all those kinds of good things. And so we do sort of raid that closet when necessary to provide things to families in order to be able to provide to the children if they're being placed outside of their family's home for drug endangered children reasons.
So the hair follicle testing we'll touch base on real quick here, but and I know that with Native Americans there might be a hurdle with the hair follicle testing, and with that in mind, you know, I mean, I think it's important for you folks up there to probably seek other options for drug testing the kids if possible. I know Doctor earlier talked about urine testing, so you know, we do the hair follicle testing often here, but our Native American population here, we don't have a lot of contact with them, and we certainly don't want to push that if we don't have to. So, but most of our hair follicle testing is done by consent. We get the parents' consent to do the hair follicle testing on the kids. If we can't get their consent, we have done search warrants. And for law enforcement, you're questioning how that's done. Basically, you're just doing a search warrant on the body. So instead of a house, you're searching the body and then you're removing the hair. And I can certainly help anybody out. You can email me and I can tell you how to do that. But that's where those are our two options with that. Usually, Human Services is the administrator, or you know, they take care of the testing. And again, there is alternative testing options out there. And so if hair follicle isn't an option for you folks there, then I would just encourage you to have some sort of testing procedure, because the testing really is good for your child neglect case, because what it shows is the exposure. And right now, our DA's office won't charge child neglect cases unless we have a positive hair follicle test. But in 7 years we've been doing this now, we have had 0 cases of child neglect go to any form of court case after the initial charging, because once you have the hair follicle test, there's little discussion over if there is an exposure or not when they test positive. If you haven't seen the test results sheet, this is what they look like. I didn't do a very good job on this. I think I have a better one further in the presentation, but this line here, I don't even know if you can see my arrow or not when I move it, but there's an amphetamine line is on the top, and then the third one down is methamphetamine, and you can see the child was positive for 980 PG/MG. I'm not even close to being smart enough to know what PG/MG is, but when my report, I just put that on whatever date I received it. I observed test results that were done on March 18th, 2015, and observed that the child tested positive for methamphetamine at a level of 980 PG/MG, and that's my report. So, but that's one of the results that we get. Taking photos, we talked about earlier with kids and documenting range and motion, height, reach. Photographs, you know, are imperative in this, that show where the danger's at. The measurements of where you find it are critical. So if we have a child that has a reach of, let's say, you know, 40 inches, we can safely say that that they would be able to reach into this drawer that contained drugs, because the drawer is 33 inches off the ground. And so, you know, they could go into that. Now, when we look at this picture here, we see the child up here. And we had a case like this where a guy told us that, hey, I keep my meth upstairs or above the kitchen sink, and that I keep it there so the kids can't get into it. And what was interesting is that I went and grabbed the kid. I think the kid was maybe 5 or 6, and I said, "Hey, where's your cereal at?" And the girl drug a stool over, just like this girl here in the picture, and reached up and showed me her cereal that was right next to the cabinet that had the meth in it. So critical or important for us to document the fact that just because the kids aren't tall enough to reach it, most kids are able to navigate the kitchen cabinets pretty easy. And so that's something to keep in mind when you're documenting where the drugs are at and if the kids have access to it or not, because that will be a defense, is that they'll say that mom and dad took such good care of the kids that they kept the drugs away from the kids and that they weren't exposed. So we'll go over, I see it's 1:15, so I'm not sure. I think we were supposed to be done at 1:15, but I'd like to go over 2 cases here if you guys can bear with us. This is a mom who is positive for meth, and what she was actually on probation for child neglect, and then the social workers went out there. And when we talk about social workers needing to know what people look like when they're under the influence, this is a perfect example. So the social worker went there to the house, recognized that the mom appeared to be under the influence, and drug tested her, and mom tested positive for meth. And so instead of not responding or just documenting and walking away, we initiated another DEC response, because at this point, mom was on probation and the kids had already been reunited from the first case. And so she had them, I think, for like 6 or 7 months prior to this. So it was kind of an older DEC case for us. But we responded and started another case, or initiated another case there. So we went there. During the interview, she was clearly high. We did a search of the house and there was nothing found. Mom was adamant that we wrap up the interview because she needed to leave to pick up the kids from the bus. And I can tell you, mom was clearly under the influence to the point where I had to stop her several times in the interview and ask her to slow down. I'm a pretty fast talker and I can usually pick up on stuff pretty quick when people are talking fast, but this woman was so fast that it made it really difficult for us. We did locate, mom finally admitted that she and her friend had used meth out on the outside of the porch, but she assured me that the kids wouldn't have any contact with it because the kids don't go into the porch. We went out there, located 4 grams of meth in a child's boot, which I thought was ironic, because she said that the kids don't go out there, but yet she's hiding drugs in their boots. We did a hair follicle test on all the kids. Here's the boot. This is the place that mom said that kids don't go to. If you can look at the picture here, you'll see that there's plenty of kid stuff and that the kids are regularly in that area. So that defense kind of went out. Here is a poor example of measuring. When you're measuring, you should show the full length of the measuring stick or whatever item you're using to measure. I should be able to say in court that it's 33 to 36 inches up off the ground, but we can't see the ground here. And so some defense attorney, I assure you, would tell me, well, we can't see the bottom of the ruler. It could be 4 feet off the ground. And so something to keep in mind. Here's the boot. There's the drugs in the boot. Again, if you don't know what all these components of all this picture are, then you should seek additional training, because these are all pretty standard items of drug paraphernalia. Here is the hair follicle test. And again, there's the amphetamine and methamphetamine. And now I learned from Lisa Hunt, thank you very much, that it is picogram to milligram. Thank you. I've been doing this talk now for 3 years and I have yet to know what PGMG is, because I always forget to look it up. So thank you, Lisa. I will point out that that in each talk that we do, we seem to learn something new by each talk from our audience. So thank you again. We'll skip through this one real quickly. Dad tells us that he hides his drugs and keeps them away from the kids by putting it in the oven. When I talked to Dad, I said, "Is this the box?" He said, "Yep, it's locked up and in the oven." Unfortunately, when he put it in there, he was high on meth and didn't lock the box because there's the lock's on there, but the clasp was not done. Here's the goodies that were in the box. Those are his track marks. So the last case that we'll talk to you about real quick was a traffic stop for equipment violation. We arrested the driver for OWI and a mom for a significant amount of meth. We found needles, scales, meth, and a pellet gun in the vehicle. And we contacted Human Services because there's 2 children in the back seat of the car. What was interesting here is that we separated. There was 3 adults in the car. We separated them, and they said that they had been traveling around the car for about a day or 2, and so we presume that the kids were in the car for a day or 2 as well. There's some of the meth that was in the car. This is the condition of the back seat. It was a minivan, condition of the back seat. This is the first child that we encountered. If you can see here, this is exactly how we found him. So he was unbelted in the car. This is a 55-mile-an-hour zone too, just to keep that in mind for your report. But here's the child. When we look at the child, you can see that the child's been in here for a while based on probably several different meals. You can see there's ketchup on the cheek, a darker form of food on the lower cheek. There's some other food debris on the chest. And then on the knees of the child as well. But most importantly here, we have the kid that's unbuckled in the car. Here's another picture of him. This is his sister. Again, not restrained correctly in the car. We don't have very good, but she's just as dirty as brother, but I just didn't get a very good picture of it. So we look at this photo here, just to keep in mind that this was Memorial Day weekend. And it was like decent, maybe in that 70s, 80 degrees during the day, but it was 60 degrees at night. And this traffic stop was, I believe, like 12:30 in the morning. What I want to point out here is that this picture was taken about 2 hours into the traffic stop, maybe an hour and a half. And what I won't do ever again is allow 2 kids that are in this condition to ever be in a car for this long. Without having medical treatment, because what ended up happening is we had to wait for a social worker to respond from their house, and they were actually on the other end of the county. So it took quite a while for the response to get there. And we felt that our best thing to do is just to keep the kids in their seats in the car and not take them out. But what we failed to recognize is that the kids were not responsive to us being in the car, weren't responsive to us shining lights, weren't responsive to almost a 20-degree temperature change. Those should all be things that everybody on here should recognize that that's probably a problem. And what we didn't do is recognize that these kids were probably under the influence of meth or were on their way down from being under the influence, or from being high. And we're in that same cycle of a 3-day user sleeps for a day. These kids were probably so impacted by meth that they were sleeping, and that they were, under the influence of meth enough that kept them unconscious basically while we were in there doing our work. And so it's really important for us to keep the kids' safety in mind. And again, I will say I was entirely at fault here, just for a lack of full circle thinking that this should have been a situation where we probably contacted an ambulance and had the kids transported immediately rather than waiting. And of course, when the social worker got there, and again, our team aspect and law enforcement looks for the drugs. We're there to talk to the parents, find drugs, take the parents to drugs or to jail. And social workers are there to take care of the kids. That's our mindset, right? That's law enforcement. So what law enforcement needs to keep in mind is that this is full circle, and that we all have a job to evaluate the kids. So of course, when the social worker got to the scene here, he looked at the kids in about 13 seconds, was like, we need to get these kids to the hospital. So that was a lesson learned for me, that will not occur again. Here's the back seat. This bag and then all the diapers on the other side are all used diapers. So they're all full, and that's what kind of led us to start asking some questions on how long had the kids been in the car, or more, dirty diapers. So this is the last slide. And so this is for everybody that's on here, but is drug activity alone a justification to intervene? Or do you wait for additional maltreatment? So if you know that there is somebody that's actively using drugs and they have kids at home and they're in charge of caring for the kids, should we wait until something actually happens to the kids, where there's physical or sexual abuse or any other forms of abuse that occur before contacting? And if we run that risk and we don't make the intervention, and we don't, try to intervene in one way, shape, or form, what if we wait too long and and the kid is a victim of sexual assault or death or physical abuse? Why would we run that risk? And so, so it's really important to start those investigations early and often, if needed, to ensure that the kids are in a safe place and that mom and dad are not using. Because the thing that I always look at is, if mom or dad can't drive a vehicle, then they shouldn't be taking care of kids. And it depends on how you look at that. We can certainly argue that all the time, or in any number of ways. But that's really one thing that I think is important for all of us here to try to keep that in mind. That we saw the doctor earlier had the statistics there that almost all the percentages double, if not triple, risk when drugs are involved, and so why run the heightened risk? So thank you all for watching this, and I really appreciate it. And we'll be happy to answer any questions either by group chat, or if somebody wants to go on there, we can certainly do that. I failed to put my email address on the slides, but we're putting it right now on the group chat, and Danielle and I will both share our email for everybody. Otherwise, you can certainly call here at the Sheriff's Department of Buffalo County. You can do that as well.
I have a question for the cases that are charged out through criminal court. What kind of, is it usually just probation or a deferred entry of judgment, or what do you normally see?
So we have Buffalo County has a CJS, so it's Community Justice Services. Yes. And what it is it's a pre-sentencing evaluation, or pre-sentencing monitoring, I think they call it. And what that is it's basically drug testing, drug and alcohol testing. So if you come in and you are arrested for meth or any controlled substance, you get put on CJS. And what they do is they do drug and alcohol monitoring, plus they get you set up with services, so treatment and all that. So we get a lot of these where they're at a user level, and they it's a DEC case. And if they go through that program and they're successful, usually there's a lot of deferred cases that come out of that. Otherwise, they're probation cases. If it's just straight possession and child neglect, we hardly see jail time from that. And most of the time, it's like you mentioned, either deferments or probation cases.
I just think with probation and parole up here anyway, limited on seeing clients, we're seeing a lot more use of the ones that are charged with the child neglect. So that's a good program that you guys have there.
Yeah, and I know that probation and parole, I think statewide, is not allowed to do any drug testing right now, or even in person, I think. So we've kind of gone, our DA's office recognizes that, and so a lot of the people are being subject to drug testing through our CJS program rather than probation and parole. You look at the philosophy of drug testing. I talk to a lot of users. I mean, I probably spend 85 to 90% of my time with folks that are struggling with addiction. And there's a lot of them that say just the simple, like somebody asking for drug testing, somebody just simply checking up on them really is a good motivator for people to keep sober. And we use it more of a tool of not to like incarcerate them again. It's more to like either ramp up their services basically that get to them. So it's not just, drug testing is not just to incarcerate people. It's to direct them in more intense services. Now, certainly does it bring people into jail? Yes, it does. But the intention is to bring more services to them rather than incarcerating them. And we've transitioned probably in the last 5 years, Buffalo County's really transitioned to a lot less incarceration and more programming.
I think that's a really good program that you guys have. And like I said, I think that, yes, we as social services can drug test, but we don't have any pull really over them. So when probation and parole is testing, they seem to like stay on the straight and narrow a little bit better than without them.
Well,
I mean,
it depends on what you classify as pull. So we have our bond conditions, follow that. The child placement, I don't know if Danielle mentioned or not, but if you're in Buffalo County and you have kids and they're impacted by if you're positive, we go to this house today and mom's positive for meth, we take the kids every time. There's no exceptions. And so until mom is clean and sober, then they start the reunification process back. And I know that's a philosophy that changes from county to county, but that's just how we do it here. That doesn't mean that that's how everybody should be doing that. That's just the choices that are made through here. So the drug testing for our human services is pretty imperative, just to make sure that mom or dad aren't using prior to them reunifying the kids.
And I know we've seen a trend where they've been able to get around the urine test. So we occasionally go to a urine test and then a mouth swab at the same time. And it's amazing what you find.
Yeah, so our CGS program, that drug testing program, they utilize 3. They have the sweat patch, they have an oral test, and then they do urine testing. And so, and they rotate through all those, just like you said, is that they'll go on, they'll figure out how to avoid the urine test, and then they'll throw a sweat patch on. The sweat patch lasts for 30 days. And so, if you don't have those 3 options, look for them, because it is nice to have an additional option. Again, you're not trying to catch the people to incarcerate them, but what you are is trying to make sure that the kids are safe before they go back with their parents. And there are so many ways to avoid urine testing, so many out there. So just by simply throwing that at them, in your case here, if you have, how do you do female and male? Like if you have dad coming into drug test, are you having him observed by a male observer, or are you giving him the cup at the door and having him go into the bathroom and then coming out? Because if it's not observed, there's 100 ways for them to carry urine into a bathroom in all shapes, forms, or sizes, and they'll do it. So, but having that mouth swab or sweat patch is definitely the next option for you.
Yeah, and the patch is something I'm not familiar with, but we've used the oral quite a bit.
Sweat patch is the same concept of why caregivers can expose their kids to meth. We all sweat, and so your body secretes the meth through your pores. And so during that secretion, kids can, if you have a 4-month-old child and you're holding the child or breastfeeding or having skin-to-skin contact, you can transfer meth through that way. And so the sweat patch is the same philosophy. The patch it's taped onto you. What they do is they draw an outline around the arm. They take a picture of it. They document where it's at. They try to, like, if you have a scar, they'll put it right above the scar. So that way, if you try to manipulate the patch, they'll know, in theory. Of course, there's always ways around everything. And then they send that patch in, and then that gets tested by a lab, and then they send it back and give you the results. And that usually goes on people for 30 days.
So it's actually more like 14 to 21 days.
Okay,
We found that after that, it does start removing itself. It just, the tape will start disintegrating at that point. So somewhere between 14 and 21 days is ideal. The interesting part about the sweat patch as well is that you don't sweat out today what you've consumed today. And so if you put that sweat patch on, it's traditionally a 48-hour look back window from the day of application to a 48-hour prior to removal date of application or date of removal. So you get, it's a little bit shifted from when you actually put it on them, because you don't sweat out what you've consumed today for about 48 hours. Our patches, so Human Services uses the sweat patch. I see a question here in Buffalo County, but we do not administer the patches. We do contract with that CJS program to do so. So I can't even answer exactly where they contract with that patch, but if you want to email Mike or I, we can certainly get that answer to you, who we are using for the patches, and share that contact information.
Yeah, I think we'd be interested in hearing more about the CJS program as well.
Yeah, it's do you guys have a CJCC, a
Community Justice Coordinating Committee? So we wrote a TAD grant is what we wrote. It's a state grant that
treatment alternatives diversion.
Yeah,
I don't know all these acronyms.
I can Google it, but Buffalo County wrote a TAD grant, and that's how we fund our CJS program. So it's I think it was a 2-year grant that we specifically wrote to create and implement the community justice services. So basically it is a pre-sentencing diversion program is the purpose of it. And so that's how we fund that. We have 2 workers that practice that. We actually share it with our neighboring county, Pepin County. And so we have a staff here in Buffalo and a staff in Pepin. And that's how we fund that. And then because they're doing this every day, all day, that's who we contract now with for the sweat patches. Human Services here does also do oral testing as well as the urine, and we do that directly from our office. But we can certainly share with you the coordinator of our CJS program. We can share you that information if you want to email me or Mike. We can get you that name and contact, and I'm sure she'd be more than willing to talk with you about the grant and how we got that approved.
That'd be fantastic. I think we've been looking at a couple of different options over the years. So
Chippewa County, I know, also has a pretty good program as far as the pre-sentencing stuff as well. They have a pretty high-tech drug testing, monitoring program stuff. So that'd be another county to check with. Anybody else at all? Questions, concerns? Have you, the social workers that are up there, have you guys had drug training? Do you know the trends, what stuff looks like? Those pictures I showed, are you aware of what those were? Anyone?
I think we're due for another one. It's been quite a while until we've had staff turnover now. And okay. I think it's time. I know the Lactoplambo tribe did a great training a while back. And I think that was repeated one other time, but it's been several years now again. So I think it's time that maybe we looked at that. Maybe we can figure out a way to put something together as a group between the 2 counties and the tribe that gets get everybody too, but it's time.
Right. I think that's really imperative to have done. And again, that's something your local, obviously the local PD should be able to do. If they can't, we can figure something out. I can come over there and do it if need be. But I generally try to get somebody local up there to do it.
Yeah, and I think our law enforcement and our IA workers that run into it all the time probably are super familiar. And then of course you've always got some turnover and some new people who could always use it. So.
Right. Well, and really everybody. I mean, like we've gone and we've done training to with the DEC stuff and with the drug stuff. We've done with that same training with all of our EMS providers, all of our fire departments. All of the teachers in our county, because I think it's pretty critical for a teacher to recognize that if mom, comes in the fall and looks presentable and then comes in the spring and looks terrible, that they recognize that maybe that's something that they should make a phone call on. And then same thing with our EMS and fire department providers. If they see drug paraphernalia in the house, I want them to call me. But if they don't know what drug paraphernalia is, I can't expect them to call. And so they have access into houses that law enforcement can't. And so I think utilizing and letting as many people as we can know about what to look for is critical.
Question, if we coordinate a drug training, could you please let us probation agents know, please? I would answer for Oneida County, absolutely, and I'm sure Kate feels the same way for Violet.
You bet.
Any other questions?
Well, we appreciate the opportunity, and by all means, you got our emails on there, and we're more than happy to help out with anything else that you folks need.
Perfect, thanks. I want to thank you guys for coming. I would like to thank, Dr. Rodriguez for this morning's training, Violets County Youth Coalition and Violets County DEC, as well as Oneida County DEC for putting this all together. That's great. I did send out in the chat my email address. If folks want a link to the presentation, I will automatically send it out to Kate, and so she can get it out to the Violets County partners. I will get it out to anyone who gets my emails for the DEC team, or if there's folks on that would like to participate in our DEC team for Oneida County, get a hold of me, Kate for Violets. Any other?
And I would just mention Julie Poupart would be the contact at Peter Christensen, I think right now for the DEC over there at Lacta Flambeau.
Yeah.
Also Alyssa Martin, who is a social worker at the Peter Christensen Health Center.
Okay. Yep. Thanks, Sue.
All right, we will get this out to you as soon as possible. We're going to have to work with our IT department to get it all into a YouTube link. It may take a couple of days, but hopefully next week. And like I said, thanks again, Mike and Danielle for coming this afternoon. And we'll let you get to your next.
Yeah.
Thank
you, everyone.
Yeah, did you have something you wanted to say?
Beth, can you hear me?
Yeah.
It's Jim Robbins over at
Hey,
Oneida.
Jim.
If you want to get with Kate and stuff like that, we can definitely put some kind of training together for the drugs and paraphernalia stuff.
Oh, that would be
that'd be fantastic.
absolutely.
Yeah, definitely.
Thanks for doing that.
Thanks, Jim.
And I just want to take a minute to thank everybody else who's participated today. It just shows that there's great interest in, fostering this approach to, drug use in our community. And I think it's just so critical for us to, make sure that we're looking to the welfare, because it is the future of our community. These kids are part of that. So thanks again for everybody who participated.
Thank you, everyone.
Good luck on your today call. I hope it's a false alarm.
We're
never that lucky.
Yeah.
Bye, everyone.
Bye, everybody.
Bye.